Only one?
Only one.
Okay.
Yeah.
आदित्य झुमकी सब आगे आ नहीं बीच में
सारे आगे आ जाओ
सारे आगे
come in the center.
Pen drive.
Yeah.
Good morning, everyone. Welcome to the final day for the GIAN program. So today for the first session, I would like to invite Professor Sujit sir to chair the first session for today.
we would start today's session with a talk on healthcare transition for adults with coronary artery lesions in Kawasaki disease.
Good morning. I greatly appreciate the opportunity to speak at this session. The first talk is initial and revisit of patient with coronary artery lesion in adult. This slide shows background in KD population. Because the diagnosis of KD is clinical symptom in the acute phase, there are some adult patients with coronary artery lesion who had not been diagnosed as KD. There are probable KD patient, adult KD patient. They are asymptomatic and they had cardiac events suddenly. This slide shows distribution of age in patient coronary artery lesion, Japanese National Survey. The number of young adult patient is more than that in children. There are 4 groups in patient with CAL: follow-up group, dropout group, revisit group, and initial visit group in adult. We investigate characteristics and treatment and adult patients who had visited in our outpatient clinic from 1995. There are 29 patients, 18 male and 11 female. The age at visit ranged from 25 to 59 years, with a median of 34 years. Initial visit and revisit were 13 and 16 patients, respectively. Cause of visit are shown. There are acute coronary syndrome, tachyarrhythmia, and abnormality in screening, ECG screening. Treatment of acute coronary syndrome is shown. There are 7 PCI and 5 coronary artery bypass grafting. A 49-year-old female visited of chest pain in 45 years old. She has sometimes chest pain. In 49 years old, she had chest pain while walking because STT depression in Holter ECG was detected. Calcium antagonist was prescribed. However, chest pain did not resolve. CTA was performed. Calcified CAA was detected, and coronary artery lesion caused by KD was suspected. She was referred into our hospital. She had persisting high fever at the age of 1 year. However, she was not diagnosed as acute KD. Her coronary angiograms are shown. Localized stenosis with giant aneurysm in the right coronary artery and segmental stenosis of the left anterior descending artery were detected. However, LV function was preserved. Treatment of arrhythmia is shown. there are 1 paroxysmal atrial fibrillation and 4 ventricular tachycardia. Implantable cardio defibrillator was done in 4 patients. A 58-year-old female visited of palpitation. Her ECG is shown. She underwent cardioversion. After DC, electrocardiogram is shown. Left axis deviation, poor progression R waves, and flat T waves were detected. She had PVC in 20 years old. She delivered 2 times safety. Although she underwent coil embolization for pulmonary artery fistula, heart disease was not pointed out in that time. In chest CT, calcified CAA was realized, and coronary artery lesion caused by KD was suspected. This slide shows calcified CAA at the LCA and segmental stenosis of right coronary artery. She underwent ICD. Her MPI is shown. Hypoperfusion was found in the inferior wall of the left ventricle in rest and stress test. A 46-year-old female was referred to in a hospital because of dyspnea and chest pain. DC performed and ventricular tachycardia. 2-dimensional echocardiography revealed hypokinesis of the inferior wall of the LV. The emergency coronary angiogram showed calcified CA and segmental stenosis. Emergency coronary artery bypass grafting was performed. Her electrocardiogram at admission is shown. Electrocardiogram after DC is shown. STT depression was found. Her coronary angiogram are shown. Segmental stenosis of the right coronary artery and localized stenosis of the LAD were shown. Treatment of ECG abnormalities in screening is shown. 2 patients in low LVEF and coronary stenotic lesion had underwent CABG in 2 patients, and 1 patient underwent ablation for atrial tachycardia. In 49-year-old female, coronary artery calcification was pointed out chest CT when she had pneumonia. She is asymptomatic. However, the occluded RCA and collateral artery from the LCA were detected in her CTA imaging. Calcification was detected. She had PVC, but she was asymptomatic. 3 female patients with coronary artery lesion visited because of delivery. 26-year-old female and 30-year-old female, 40-year-old female. 3 patients had segmental stenosis of the right coronary artery. A male patient with heart failure had had acute KD in the age of 5 years. When he was 10 years old, heart murmur was pointed out in school screening. Coronary angiogram showed the occlusion of the RCA and aneurysm at bifurcation of the LCA. Mitral regurgitation was detected. He did not visit our hospital at the age of 16 years. In 43 years old, he was referred to our hospital because of heart failure. His right coronary angiogram are shown. RCA was occluded. Serial coronary angiogram of the LCA are shown. Aneurysm at bifurcation was persisted. In his electrocardiogram, atrial fibrillation was found. He underwent CABG and mitral valve replacement. Although his heart failure improved, he died suddenly during running. Patient education and regular follow-up are mandatory. Treatment for ischemic heart disease is shown. Clue of diagnosis for coronary artery lesion caused by KD is shown. Calcification in chest X-ray and CTA. ECG abnormalities indicate low LVEF. Ventricular arrhythmia was detected. Sudden death in young adult. Calcified aneurysm and segmental stenosis was popular. Next talk is death in patient with coronary artery lesion. Prevention of late death in patients with coronary artery lesions resulting from Kawasaki disease remains an important challenge. To better understanding characteristics of death is useful. We encountered 30 patients, 5%, in patients with coronary artery lesion, among 572 patients between 1978 and 2020. We analyzed their clinical course and causes of death to identify risk factor for death. Since 1977, number of deaths in 1980s and 1990, most of this occurred. the onset of KD in such patient he had acute KD in 1960 and 1970. The pie graph the next graph shows the number by age at death, which ranged from 1 to 17 years, and the median was 21 years. The interval from acute KD onset to death ranged from 2 months to 56 years, and the median was 80 years. The proportion of sudden death was 60%. Heart failure and non-cardiac death were 20%, respectively. This pie graph shows the number of deaths from various causes in patients with cardiac death. 6 patients died of heart failure. The remaining 18 patients died suddenly. Although 4 patients died of acute myocardial infarction, it was unknown in 12 of the others. Non-cardiac deaths were found in 6 patients. Heart failure was found in 6 patients. They had repeat MI. Sudden death due to AMI was found in 4 patients in 1970 and 1980. Inferior MI and anterior MI were found in each 2 patients. Unknown sudden death was found in 3 patients. The age death ranged from 1 to 43 years, with a median of 26 years. Low LVEF and dropout were found in 8 and 3 patients, respectively. 3 patients in dropout group had some risk factors. In this slide, we see the time and cause of certain suddenness. In the 1970s and 1980s, suddenness due to acute myocardial infarction tend to occur within a few years after acute KD. In contrast, in 1990s and 2000, unexpected and sudden death occurred in patients with myocardial infarction many years previously. We will illustrate the problem by presenting 3 cases. First, in 1988, a 1-year-old boy with bilateral giant coronary aneurysm died suddenly after taking a bath. A 50-year-old boy collapsed while playing football in 1990. Coronary arterial lesion due to KD were detected by school electrocardiogram examination. When he was 13, he had bilateral stenotic lesion. Although advised not to exercise by his doctor, the patient failed to follow the advice. This 50-year-old girl was referred to a hospital with heart failure due to myocardial infarction and mitral regurgitation. Coronary angiogram are shown in this slide. RCA was occluded and giant aneurysm at the bifurcation was persist. Her coronary angiogram, although she had coronary artery bypass grafting to the LAD, the graft was string because of compete with the native flow and graft flow. Her ECG is shown. Abnormal Q wave was detected. Chest X-ray is shown. Calcification was detected. Changes of left ventricular diastolic dimension and LVFS are shown. After CABG, beta blocker and ACI were prescribed, and her heart failure improved. Further, she had a low left ventricular ejection fraction. She had frequent asymptomatic non-sustained ventricular tachycardia. She unexpectedly collapsed immediately after chest discomfort at midnight 2002. The cause of death was unknown. A 20-year-old male with mitral regurgitation died suddenly after he complained of chest discomfort. A 26-year-old male with low LV and NSVT collapsed in parking. Here we see the relation between the interval from acute KD and left ventricular ejection fraction. Most of patients with late sudden death more than 20 years after acute KD had a low LVEF. Furthermore, the illustration showed the relation between the left ventricular function and ventricular arrhythmia. Most of patients who died suddenly also had non-sustained ventricular tachycardia and low LVEF. Most of patients with unknown death had previous myocardial infarction in 1917 and 1980. Survival rate was low in such patients. Characteristic of death in patients with coronary artery lesion caused by KD. 1, sudden death and heart failure. The early period within 2 years and late period more than 15 years. Sudden death related to acute myocardial infarction and previous myocardial infarction. Heart failure due to low LVEF caused by repeated MI. Fatal ventricular arrhythmia with low LVEF. Cardiac events in drop other adult patients. It's over 50 years since the first report of KD and coronary artery aneurysm. Diagnosis and treatment for coronary artery lesion caused by KD has improved, not only for acute KD. Therefore, there are some characteristics of death by decade. In the 1970s, and sudden death occurred during exercise, and cardiac sequelae were first diagnosed at autopsy. In 1980s, death related to acute MI occurred within the first year after the onset of KD. The 1990s, unexpected death in the late period occurred in patients with left ventricular dysfunction. In summary, 24 patients, 86% had a bilateral giant aneurysm. 16 patients, 57% had a previous myocardial infarction, and 8 patients, 29% had an asymptomatic occlusion. 15 patients, 54% had a low left ventricular ejection fraction, less than 45%. 8 patients had undergone CABG after myocardial infarction. 2 underwent PCI and they had complications. 2 had undergone implantable cardiodefibrillator. 2 had undergone heart transplantation because of intractable heart failure. Most of deaths in this population occurred suddenly. Most of deaths had had previous myocardial infarction. Preserved LVEF and antiarrhythmic therapy would be needed to prevent death. Kawasaki disease in acquired heart disease, which causes CAA in the acute phase, and stenotic lesion and myocardial involvement in the late phase. Its outcome depends on the nature and location of initial aneurysms. Understanding of the aneurysm caused by KD is very important for the management of this population. Thank you for attention.
Thank you, Dr. Suda. This talk is now open for comments. So at the NCDC in Osaka, they have probably the world's largest experience of long-term management of children with Kawasaki disease who have now become adults and that have various problems because of Kawasaki disease. So Dr. Suda is perhaps the most experienced physicians to be handling these patients anywhere in the world. And she and Dr. Kitamura have published extensively on their follow-up of these patients. And this team was amongst the first few teams to evaluate the role of coronary artery bypass grafts in patients with KD and the long-term follow-up of these patients. So we are way behind what they have done. And as we discussed yesterday, there are very few bypass grafts that have been done in India. So I am aware of just 3 or 4. And these were done during the acute phase because the children, they developed MI during the acute phase of Kawasaki disease, and these had to be done in a hurry. But bypass grafts for long-term follow-up, I am not aware of, in fact, any such patient. these patients nevertheless are there out in the cardiology clinics. They need to be identified, they need to be taken up for more systematic management. So any questions?
Thank you very much, Senator. I have two questions for you. Number one is, once the patients have undergone coronary artery bypass grafting, what is their outcome in terms of graft failure? Is it similar to atherosclerotic lesions and bypass? Like what we say, 2% per year is the degeneration of grafts in older patients because of atherosclerotic coronary. Is it same or is it different? Especially when we know that the other systemic arteries are also involved. Do they affect internal thoracic artery also? Will it alter the graft failure rates?
In Kawasaki disease, competition and native artery and graft flow was sometimes detected. But the graft was patent at 1 to 2 months. If patent, the patency of graft persists more than 20 years. Okay.
And second question is, how about stenting? Percutaneous intervention like angioplasty and stenting.
Yeah.
What is, has it been done extensively for Kawasaki disease, coronary artery disease? And what is the outcome of that?
The number of PCI in Kawasaki disease was very limited, and it's difficult to evaluate the outcome. But in older children, it's okay. But small children is not good.
Not in children, adolescents or adults, like 20s, 30s, who had myocardial infarction with history of Kawasaki disease in childhood, when they have coronary lesions. Stenting in adults with history of Kawasaki disease.
Stent.
Yeah.
In reference to first generation stent, complication was reported in some patients. But second generation stenting is short time, not so bad in adult cases.
So what is the current practice in Japan? So in last 15 years, the stents have improved tremendously in terms of their designs, their strut size, and the complication rate of stent thrombosis or stent restenosis rates have come down because of change in making of the stents.
Yeah.
So are you advising bypass grafting as first option in last 5 years for patients with Kawasaki adults?
Yeah.
Or you are attempting the stenting or angioplastics in last 5-10 years? Is there any change in practice?
With improvement of PCI, the selection for coronary revascularization may be changing. But coronary artery bypass grafting is good for children. Graft patency was good if 1 month, if patent in 1 month is okay.
because we attribute all the sudden death that occurs in the community for related to the aneurysm occlusion, because we don't expect them to have a stenosis at a faster rate. So do we need to consider these arrhythmic events also in here?
As a cause of sudden death?
Yes, sir. In less than 2 years from the onset of illness.
The question is arrhythmia also an important component for the sudden deaths?
Yeah.
Sir, or is it only because of ischemia, coronary ischemia?
Yeah, one patient had coronary myocardial ischemia, but another patient had not myocardial ischemia. She had fibrosis of left ventricle due to previous myocardial infarction. Fibrosis of area can induce fatal arrhythmia after many years.
My concern is in the early phase, not once they cross the adolescent or adulthood. In the initial few years from the Kawasaki disease, have you encountered arrhythmias in such period also, and less than 2 years from the illness also?
So after Kawasaki disease, in the first 2 years, how frequently have you encountered arrhythmias?
Yeah. No, in children, there are rare arrhythmia in children, but in more than 20 years, ventricular arrhythmia occurred. Sorry.
The question is, Sanjeev, how many centers in our country would be comfortable doing bypass grafting in these patients?
As far as bypass grafting is concerned, there should not be a major concern if the age of the patient is more. Because
More than?
sir, it is technical thing. Adult size is achieved by the age of 10 or 12. So the problems comes if they are very small, because they have to suture the lima and rema to the distal or the mid-LAE and distal RC. They need at least 1.25 to 1.3 millimeters of the diameter of the target vessel. So lesser than 1.3 millimeters, they find it very difficult to suture.
So in the pediatric cardiology community in India, are such patients discussed?
Not much, sir, not much. We have some half-an-hour session in ECSI every year for acquired heart disease in children, and majority of the discussion will be on the diabetes or the rheumatic heart disease. Kawasaki is hardly discussed. Maybe 10 or 15 minutes talk will be there over entire 4 days.
So, and I am aware of 2 bypass grafts that were carried out in Coimbatore, but both during the acute stage as a salvage measure, and one in Delhi. But all these were a long time ago. After that, I don't think we have, I haven't heard of any bypass grafts in Kawasaki disease.
Sir, in children, I am not aware of any bypass graft being done in last 10 years at least, not in my knowledge. But in adolescents and adults, I remember 3 patients when I was 2011-12 during my DM course in Chitra. Adolescents, and one was 20.
For Kawasaki?
History of Kawasaki
At Sri Chitra.
Yes.
And
It was in early 20s.
it was uneventful?
Uneventful. He was discharged, and I have one follow-up remembrance also for 6 months or so. He was doing that.
Any other questions?
We are, that is there in my mind about this, because the survival, I am talking about that in the next talk. The survival and outcome has improved tremendously thanks to you all. So we expect lots and lots of patients to come to us in next few years with either history of Kawasaki disease now asymptomatic, or with coronary artery lesions recovered, improved, regressed, or with persistent lesions, giant or smaller or moderate, with or without symptoms, with or without LV dysfunction. So it is, in my own effort, I have identified 5 centers with my colleagues, friends, and juniors and my students. One in Jayadeva, Bangalore, the Pondicherry, Pgimer, NH Kolkata, Jupiter, Bombay, and I have requested this all in India, so that we can have at least 5-6 centers to have little preparation for the next 5 years. We expect them to come in by the end of next decade or this decade to have symptomatic coronary disease in adolescents and adults with history of toxin.
So I think you were not there yesterday in that session, but we have had one sudden death last year. This child had LAD stenosis, and he died suddenly while on a run in the morning. And we have another 4 patients with LAD stenosis who need some intervention now. So that cohort will keep on building up.
Yes.
So as these children grow.
Yes. I'll be happy to see that patient. I have Dr. Rupesh, Pankaj, and Mahanand are keen to operate on such patients if they need any restoration. We are in sort of forming the group to manage such patients. I remember that when we were taking rounds in 2008 April, my exam time, Jovan Jot, an 8-year-old boy who had sudden chest pain and demise when we were taking rounds in the ward. So it is not that rare. I think once in a few years you might be experiencing this. We need to address that's what I was asking ma'am, can we attempt as a bailout either an angioplasty or stenting? So that now we have lot many options, absorbable stents have come. There is not a concern. If we have any evidence, otherwise we have to make our own data, our own efforts, and make it a documentation as what ma'am has told last 5 years. If we do efforts, put efforts in next 10 years, we can come up with such data in next 25 years.
Okay. Thank you very much.
Thank you, ma'am, for this session. Now for the next session, I would like to invite Dr. Rakesh Planyasef to chair the session.
Good morning also. In continuation with this, may I request Sanjeev Nadu is Additional Professor in the Department of Cardiology and Advanced Cardiology Center, Pgimer, and Sir will be speaking on the healthcare transition or what is the situation in India and how we will be planning to deal with these cases.
Thank you, Rakesh. I thank the organizers for this opportunity. Well, as you all know, the understanding and management of Kawasaki disease has come a long way in last 2.5 decades or so, thanks to Professor Sujit Singh sir in North and his team, and Dr. Saji Philip, Professor Zulfikar Ahmed, Dr. Nageshwar Rao down south, and their teams, of course. So, and their subsequent generation is doing a great job to carry it forward. So, as the survival and outcome of Kawasaki disease in children is improving, it is but obvious that they will be having one or the other issues when they grow up. So absolutely necessary in next few years and decades is the need of understanding of what they are going to present with when they grow up as adults. So hence this topic is perhaps of utmost relevance in the given Indian scenario. So scope of my talk will be under these headings. So what will be the usual adult presentation of childhood Kawasaki disease with respect to coronary involvement? Very, very brief literature review. How do we evaluate? Basic evaluation of adolescents and adults with history of childhood Kawasaki disease. coronary angiography and intracoronary imaging, if we perform on these patients, what are we going to find and what is the indication and so on and so forth. How to assess in terms of functional status of coronary artery lesions, and how do we manage them medically and what we can offer in our setup, and revascularization options for obstructive coronary artery lesions, what we can offer in our setup. So adults with history of childhood Kawasaki disease can come to us as grown-ups with no cardiac involvement during acute illness. They can just come for the information or as follow-up. With acute illness, history of acute illness with complete recovery also can present to us when they grow up. Cardiac involvement during acute illness with non-coronary sequelae in terms of systemic artery aneurysms or mitral regurgitations or other valvular regurgitation can be the presenting symptom to us. So the interest of topic given to me is cardiac involvement during acute illness with coronary artery lesions. What is their fate or what is their outcome, and how we can offer them service when they grow up as adults. So you might have read this great study published long back in 1996, so which studied extensively about nearly 600 patients with long follow-up as long as 21 years of 600 patients. What did they do? They examined one every 3 years of all Kawasaki disease infants without coronary artery lesions. Small and medium-sized coronary aneurysms or regressed aneurysms were followed every 6 months. Giant aneurysms were followed every 3 months. So what did they find? The incidence of coronary aneurysms in acute was 25%. 55% of them showed regression, and ischemic heart disease developed in a nearly 5%, with MI in nearly 2% and death in just less than 1%. So this is what is important, isn't it? So what did they confer? So they questioned the need of long-term follow-up of children with normal coronary artery or long-term, and I believe, and many of the people believe, that they need to be followed every 3 to 5 years, at least clinically. And patients with transient dilatation, they felt as there was no cardiac symptoms or ischemic findings in the long run, they thought the study is what I quoted, they thought there is need of long-term follow-up in terms of screening for coronary artery disease or premature atherosclerosis in the adulthood. So they also found when they did intravascular ultrasound later on, there is marked intimal thickening with or without calcification even in regressed coronary artery aneurysms. This is very important. Coronary artery wall was poorly distensible when they administered intracoronary nitrate. So vasodilation was less pronounced compared to the normal coronaries. So it is understandable now that the sequelae of Kawasaki vasculitis may be present even in patients with regressed aneurysms, and atherosclerotic lesions might develop in early adulthood in such patients. So hence it is absolutely necessary, as you all aware, Indians or Southeast Asians are inherently at higher risk of developing atherosclerosis at much younger age, less than 15 years compared to the West. That is because of the genetic thing, SNP genes you might have read involved with us. So it is absolutely necessary, because there will be a lot of overlapping if a 30 years old comes with atherosclerotic changes with history of fever in the infancy. So it is absolutely necessary for us to understand and avoid other atherosclerogenic risk factors, for that matter in normal people as well, especially in such patients, to avoid smoking, avoid getting obese, and screen and treat systemic hypertension, and of course the LDL levels keep them in the normal range. So I searched a few case series reports and articles. The average says that the giant aneurysms are the things which needs to be considered if we need to follow them. So around 70% of myocardial infarction patients give history of giant coronary aneurysms when they grow up. That is the patients with history of Kawasaki disease in childhood. So around 50% of them develop stenotic lesions, making them to have symptoms of coronary ischemia. And none of them are likely to show any regression. So this is the subgroup which have to have a constant and regular follow-up. So what is the average presentation? As ma'am told, in their study it was 21 years, isn't it? The other study said it is almost similar. On 25 years of age is the usual age of presentation with cardiac sequelae, either coronary ischemia or myocardial infarction or arrhythmia or diastolic or systolic heart failure. Ischemic symptoms predominate the symptomatology around 60%, arrhythmias around 10%, and sudden cardiac deaths around 16%. As one of the attendee was asking, sudden cardiac death risk in the infancy. See, to have a sudden cardiac death, there has to be two things. One is pump failure because of complete occlusion of a major epicardial coronary artery, or an ischemic ventricular tachycardia, which can cause alteration in the perfusion of myocardium and other vital organs leading on to the death. So either it has to be a complete occlusion because of the thrombus in the aneurysm, or it has to be an ischemic ventricular tachycardia which has caused sudden death. So what is the role of cardiology services? What is the role of adult physicians and cardiologists in such patients? We have to follow them even if they are not having any symptoms. We have to treat them with antiplatelets if there are persistent aneurysms, and statins depending on what is there in their lipid profile, and follow them closely, at least once in a year. And giant coronary artery aneurysms need to have anticoagulation and very close follow-up even if they are not having any symptoms. And what if there is evidence of obstruction either on non-invasive evaluation or by the clinical symptoms? So there can be a subgroup where there is obstructive coronary artery disease but there is no ischemic symptom on exertion. So that needs a medical follow-up along with antiplatelets and statins. So obstructive disease with atypical symptoms, some chest pain here and there, but not typical of ischemia, they need to be evaluated for objective evidence of inducible coronary ischemia. And typical ischemic symptoms on exertion, of course, needs to have the revascularization as and when it is required. And obstructive coronary artery disease with history of myocardial infarction may be the presentation of such patients in the adulthood. Then we have to understand whether the infarcted segment is viable or it is not viable to decide on need and mode of revascularization. So how do we evaluate? So clinical evaluation in terms of assessment of ischemic symptoms. Is there any obvious symptoms or ischemic equivalent like dyspnea on exertion rather than typical angina on exertion? And we should always assess other ischemic heart disease risk factors, especially in our setup in terms of family history of premature atherosclerosis, either coronary involvement or cerebrovascular involvement. Examination in terms of body mass index for obesity, signs of premature atherosclerosis, resting ECG for baseline ischemia, is there any STT changes or Q changes at the baseline to have a fair idea about their coronary status. Chest radiography, I was amazed to see the calcification of coronaries on the chest x-ray that we usually don't find when madam showed that. So chest radiography, presence of pulmonary venous hypertension is a fair idea of elevated LV and diastolic pressure, which may be secondary to the demand-supply mismatch of coronary ischemia. Resting echocardiography for regional wall abnormalities if it is resting coronary ischemia, and of course LV function needs to be assessed so that we can have better planning. And strain imaging is what is we are working with Dr. Rakesh and the radiology team to understand what is the strain imaging. Even if the resting echo, two-dimensional echo is normal, then we can assess with the strain imaging to assess the subclinical LV dysfunction so that we can correlate, so that we can manage better when they have symptoms. And fasting lipid profile, HbA1c, because we are at higher risk of developing all these abnormalities, high lipoprotein A levels, high homocysteine levels, high sensitivity CRPs. This is for the overlapping or ruling out non-Kawasaki premature atherosclerosis. So these needs to be evaluated for anybody presenting to us with ischemic symptoms with or without history of Kawasaki disease. So obstructive coronary artery disease, no ischemic symptoms on exertion, needs to be assessed for their coronary anatomy, LV function, and this compliance for antiplatelet statins. And we should do workup for inducible ischemia, even if they are not having symptoms on clinical evaluation. And if they have history of myocardial infarction, either by history or by ECG and echo findings, we need to assess their LV function and of course the viability to decide on further management. So once we do this basic evaluation, then we come to the proper assessment of coronary ischemia. I think we have a special session, or is it over, for the CT assessment. I am not going into the details. So this is an ideal thing for a screening tool for patients with Kawasaki disease now presenting in adulthood. What is the status of their CT coronary angiography? This is an excellent tool for screening. And assessment for inducible ischemia for patients who are having positive coronary angiography on CT in terms of calcium score and having plus minus symptoms. So this is an excellent tool to assess them for the need of revascularization. Exercise stress test, what we call TMT, treadmill test. Stress echocardiography with the injection of dobutamine. Thallium myocardial scintigraphy, thallium 201 radionuclide scan. Invasive assessment in terms of conventional angiography, what we do routinely for adults. Intravascular ultrasound, optical coherence tomography, fractional flow reserve, these are the functional assessment, quantitative flow reserve assessment, quantitative computed angiography analysis, and CFR. So in exercise test, what we do, it's a simple thing. You attach a 12-lead ECG, and there is graded increase in the patient's efforts in terms of metabolic equivalents. And you see for the changes in the heart rate, the blood pressure, and symptoms, whether he's having any angina or anginal equivalents. And you see for the objective changes in the ECG. As you can see, this is on exertion. You can see there is significant ST depression in 1-3 AVL, elevation in AVR, and V3 to V6, there is significant ST depression, isn't it? This is consistent with coronary ischemia when he is exerting on the treadmill. So suggesting that the coronary blood flow is not enough when he is exerting. So another non-invasive modality to assess is stress echocardiography. You assess the LV function, regional wall abnormalities, mitral regurgitation, and strain at rest, and you give dobutamine with sequential increase from 2.5 to 20 mics per kg. You assess for their new onset regional wall abnormalities, new onset or worsening of mitral regurgitation, and new onset LV dysfunction or regional wall ventricular dysfunction on stress. So this is positive stress test in terms of echocardiography stating that there is evidence of coronary ischemia. So thallium myocardial scintigraphy, as you can see, the resting and at exercise there is a lack of perfusion, isn't it? Again stating that this is the positive thallium. So coronary angiography is not routinely indicated in any adolescent presenting with history of childhood coronary artery disease unless he has evidence of coronary ischemia on clinical and non-invasive evaluation. So this is as per the Kawasaki Research Committee, how you divide the dilated lesions, because the management will be a little different in terms of revascularization if we attempt percutaneous one, and stenotic lesions, whether they are completely occluded, is there any segmental stenosis or localized stenosis. So everybody agrees these days just doing angiography is of lesser use, and it is best combined with intracoronary imaging so that we can better understand the pathoanatomy and the management can be advised in a better way. So this is the intravascular ultrasound. As you can see, this is, you take reference of proximal and distal coronary artery diameter or area by intravascular ultrasound, and you compare with the dilated segment, you will understand that the aneurysm diameter and area will be much higher. So not only that, you can understand the calcification state and microvessels, as you can see here. Microvessels development indicate that there are microthrombi and fibrosis in the intima as well as media, which is at higher risk of having a coronary event in the near future. So we can assess the aneurysms, we can assess the stenosis. As you can see, the usual site of stenosis is the junction between the aneurysm and the normal segment. That is the usual site of obstruction or stenosis in Kawasaki disease. Whereas in atherosclerosis, the lesions will be more diffuse rather than localized. And this is from our own lab. As you can see, this is dilated, isn't it? This is how you see in the intravascular ultrasound. And this is what is known as negative remodeling. You can see this is bigger, this is smaller, right? So that is because of the fibrosis or the negative remodeling, what we call. And this is the calcium, this is the hyperechoic lesion, is the calcific nodule, not this white one, the black one. So stating that the hyperechoic lesion is calcific nodule in the left main coronary artery. This is fibrotic plaque. You can see it's a relatively longer segment lesion. So the advantage of IVUS is it does not require any contrast, but the disadvantage is it is invasive and it needs some training to understand and interpret these images. We have another modality, all these are available with us in our lab. So that's why I'm stating that what we can offer to the patients when they visit us. So OCT is optical tomography, where you can see it's a post-tented status. As you can see, this is the long vessel view, what they call. So this is more dilated, isn't it? So that is the aneurysm. Though you can assess what is the length of aneurysm, what is the diameter of aneurysm, so that we can decide on the stent. So stent appropriate apposition to the wall will prevent the risk of thrombus in between the stent struts and the vessel wall. You understand? So, and this is the calcification. As you can see, this is the calcific nodule. This is protruding, not this one, the behind one. And these are the superficial calcium, the less colorful things. And this is more deeper calcium. These are best appreciated with the help of OCT. This is what we routinely do for adults having coronary artery disease because of atherosclerosis. The advantage of this OCT is it is very easy to understand. You can see the colorful pictures and you can understand and interpret, but it requires contrast, which may be a little tricky because every injection requires some 20 ml of contrast. So it is a little tricky and it is of course invasive. And functional assessment, if you are not sure based on the anatomy and clinical symptoms, we can do what is known as functional assessment of coronary artery lesions. This is QCA, quantitative coronary analysis. This is all software computer driven thing. You just put a point here, and we can get what is the percentage of narrowing, what is the percentage of luminal area at that site, and what is the plaque burden and what is the status of the lesion there. And quantitative flow reserve is the combined FFR and QCA, where we can easily identify whether the lesion is significant enough to cause coronary ischemia. Is it significant enough to make the patient to have coronary complication in terms of myocardial infarction or sudden death, so that we can decide on intervening that lesion. FFR is probably the most specific thing. You measure the pressure before the lesion and after the lesion with the help of this pressure wire. And the ratio of that obviously give the severity of this lesion. You do at rest and you make the coronary hyperemia by giving intracoronary adenosine or NTG, and you assess less than 0.8 is considered as significant, stating that this lesion is quite significant for this patient. So apart from assessment of coronaries, it is important for us to know that there is very common is premature atherosclerosis in our setup, especially in 30s. As we know that the incidence of coronary artery disease in India is rising, and 1/4 of 25% of patients having myocardial infarction in India are aging less than 40 years. So less than 30 years, MI is contributing to 15% of myocardial infarction and death in India. So if somebody of age 28 comes with myocardial infarction, not necessarily it is premature atherosclerosis alone. In the same way, it is not necessarily to be because of the childhood Kawasaki disease. So we need to understand and try to differentiate, because the management will be a little different in terms of family screening and prevention of similar things in the family if it is atherosclerotic lesion rather than the Kawasaki disease related. Kawasaki will not be familial, right? So as I have mentioned here, the age group, history, family history, associated other coronary artery disease risk factors, involvement of coronary, either it's ostial or proximal, presence of calcification, all will help to differentiate Kawasaki disease with premature atherosclerosis. The important is, as ma'am also agreed, PCI, as per the available literature, PCI is not the best as far as Kawasaki disease is concerned, whereas it is proven beyond doubt in thousands of studies that PCI, that is percutaneous coronary intervention, angioplasty and stenting, is not inferior to CABG in selected cases. So there comes a difference in the management. So challenges for percutaneous intervention in Kawasaki disease is presence of very high calcium. Almost always they will be calcific. So to modify that plaque which is having high calcium before putting a stent is very, very tricky, because the stent has to expand properly so that we can minimize the risk of stent thrombosis as well as stent restenosis. And complications will be much higher if the calcium is higher. Instant restenosis rates are higher if the calcium is quite high. And aneurysm will put challenge on us to decide on selection of the stent, and the risk of stent thrombosis is higher because the slow flow rate after stenting is higher. If aneurysm mein flow kam ho jata na, when the diameter is more, the flow will be lesser. So that will be a challenge to manage in the post stenting status. And multiple segments if they are involved, selection of stent and stent restenosis will be challenging. And bifurcation lesion, when it is at the very origin, and bifurcation, size discrepancy, if at all it is there, it has got some technical issues, but it can be tackled. And for challenges bypass graft ke liye, I think again calcium and aneurysm are a little tricky, and for surgeon it is little easier because it's almost always proximal vessels are involved, and they put a graft always in the mid segment or much beyond the mid segment. So for them it is okay. That's what I am not aware of graft failure rates in Kawasaki disease compared to atherosclerotic disease with graft long-term outcome. And experience of surgeons is little lacking in our setup. Maybe next few years it should be okay. So what techniques we have in our setup, in our own lab in PGI to tackle this high calcium? We have cutting balloon devices, the wires at the edge of the balloon, we can tackle that calcium. We have rotablators, a diamond tipped burr where we can drill the calcium. We have orbital atherectomy where it rotates in both directions so that the calcium can be taken care of so that the stent can be placed easily. We have shock wave, similar to what we use for calculus anywhere else. We have in the coronary calcium ke liye bhi. So the balloon and the shock wave will reduce the calcium load so that the stent can be implanted easily. So in my opinion, the challenges in Indian scenario are quite high. We need to have further improvement in knowledge, attitude and practice in terms of Kawasaki disease in the periphery of our country. And we should be aware of the sequelae in adulthood. All physicians should be aware of it. We tried our best when we started our program to give exposure to the basics of coronary artery disease for pediatric cardiology trainees and the basics of coronary artery disease management when they face such patients in their future. And adult cardiologists, our trainees are given the best possible knowledge of Kawasaki disease and its long-term cardiovascular sequelae, but they are not that interested, as you can see from the attendance from my department. Dedicated team is the need of the hour. The pediatricians, the radiologists, the cardiologists, surgeon and adolescent medicine is perhaps a newer subgroup. We need to form a dedicated team to tackle such patients when they visit to us, and we need to form consensus or guidelines for the management of symptomatic and for the management of asymptomatic obstructive coronary artery disease in grown-ups with history of childhood Kawasaki disease. We need to have our own consensus and guidelines so that we can manage them better when they fail. This is what I have shared with my friends. I propose this protocol. I'll share with you all. We can think on this, modify this and make up with the plan when we need to face patients with history of coronary artery disease in their childhood. So with this, my take-home message will be very simple. Kawasaki disease, originally a disease of infants and young children, is going to be perhaps very high on the lists of acquired heart disease in children and young adults in the near future. Coronary artery disease sequelae of Kawasaki disease will be an important cause of ischemic heart disease in young adults in the near future. One should always elicit the history of childhood Kawasaki disease in younger patients with ischemic heart disease. This is for the physicians. And Kawasaki vasculitis can independently develop into premature atherosclerosis in adulthood. We need to be aware of this. And percutaneous and surgical revascularization is challenging, but it is definitely feasible. And dedicated team and center will be an absolute need in the next decade to manage such patients. Thank you very much.
Thank you, sir, for such a busy talk. So we have taken us through face these challenges earlier than better. So we have seen that in coming years we have to see many patients with those who will be presenting with a myocardial ischemia or acute coronary syndromes because of Kawasaki disease. So both talks are being open for such talk is also open for comments or questions.
So just to have the basic idea about this, what we can expect in the future, what study you are doing, I'm trying to look for the subtle ventricular dysfunction, subtle wall motion abnormalities by tissue Doppler and strain imaging. We have found a couple, once we correlate with them with the MRI and other echo and other things, we can come up with a little bit of better information in asymptomatic patients.
Yeah, very interesting. I won't use the word very scary and challenging problem we are going to face in the future. So, since I'm in a teaching hospital and planning to give a thesis, or we can do a research multicentric trial where we can have a combined study with the cardiologist. So all those MIs, because in Hero Heart Center we are getting 25, 27 years with diffuse coronary disease needing bypass. Stents have no role there. So we are getting lots of such patients, but we do not know now. Retrospectively, I think maybe it is because of underlying coronary. So maybe combined study with cardiologists and pediatricians, all those adults less than 50 years having MI, and all those children with KD. I mean, we can have a study for a long time. So maybe a multi-centric trial. We also get lots and lots of patients in EMC, and PJ of course is the number one in the country. Thank you, sir.
Ma'am, regarding diffuse atherosclerosis or diffuse lesions, so we need to be doubly sure whether it is premature atherosclerosis versus such Kawasaki disease sequelae.
What test would help? Calcification? How will
So, no ma'am, calcification we have seen at the age of 19 also. We have to correlate everything, right from family history to LDL receptor status to their genetics to their smoking to their body mass index to their lipoprotein levels, their homocysteine levels, and their coronary status in terms of angiographic findings, presence of calcium, and what segments are involved. Is there any aneurysm associated with stenosis? And everything taken into consideration, then we can have a better understanding. And of course, the coronary imaging, whether the calcium is localized or calcium is diffuse, whether it is node.
go in favor of aneurysm?
No, localized always indicates the inflammation was at that point, right? That goes in favor of Kawasaki, because the involvement of coronary is segmental, is localized, no, rather than whole of coronary.
That's a good idea, because cardiologists' eyes will see what the mind knows. They are not even aware of AD. So they may not be looking from that point of view. That's why they just label diffuse. But it could be underlying aneurysm. So that's a good way to.
Yes, yes. The other thing is at least at this point of time, there is no major difference in the management of coronary artery lesions once the infarction has already occurred. Once the part is dead, that LAD territory is dead, then the treatment will be for the other vessels and conservative management. If it is ischemia proven, then the treatment is easier, either percutaneous or the surgical revascularization. The question comes with borderline stenosis, with dilatation of 2 times or Z-score of just +2, +3, with or without symptoms, question comes there. Because it's obvious is obvious. So we need to catch them before it is obvious.
For this, the vitamins discussed, is there any particular age cutoff after which we can do it? And if there is an age cutoff, then is it related to the vitamin-related arrhythmias or something else also in side effects?
So if there is already manifest ventricular dysfunction, then it is not going to help you much, isn't it? So dobutamine, by the virtue of increasing myocardial contractility, heart rate, making the heart to have more demand, will help us whether there is any ischemia when the heart is under stress. And there is no cutoff. We can do at 10 years also, we can do at 12 years also, adults also we routinely do. There is no cutoff as such. And yes, there is always a risk of, we always take consent of arrhythmias and developing MI, even during treadmill. because they are at risk. They may develop MI when they are running on treadmill. Even dobutamine injection, they can have coronary ischemia.
And sir, the obstructive reasons with the underlying infarction, so beta blockers versus ACE inhibitors, which of these is the preferred one and which will prevent the cardiac remodeling better in between?
Cardiac remodeling is always ACE inhibitor. Beta blocker is going to have effect by reducing the myocardial demand, by increasing the diastolic filling period, reducing the heart rate. Diastolic time will be more, diastolic filling will be more, coronary perfusion is during diastole, the perfusion will be better, LVDP will be better if the heart rate is controlled in terms of that. Both needs to be given, but isolate if you say cardiac remodeling के लिए A is better or B, ACE inhibitors are proven to be better.
Thank you, sir.
Thanks.
If there are no more questions, we can take a quick break for the reassemble in 10 minutes.
Thank you.
टी ब्रेक के बाद वाली है डॉक्टर संदेश के साथ मेरा आपने दे दिया। मेरा शिफ्ट पूरी करके आपको सर्च करना होगा।
now I invite Professor Deepthi Suri ma'am to give her talk on impact of KD on adult coronary artery disease. Deepthi ma'am was my SR and my mentor for last 20 years now. Please ma'am.
Thank you, Sanjeev. Those are very sweet memories that we had of working together. I am given the topic of impact of KD on adult coronary artery disease, and I think after the previous two beautiful talks, this may be a little bit of repetition, but I would want to share what I understand about KD affecting the coronaries. Especially in adults. So we all know that KD can sometimes present in adults, and this can be a rare phenomenon. And patients with acute KD can have more chances of coronary artery involvement because of late diagnosis. So in adults you may have acute KD, and we've had multiple such cases, but it can also have an adult presentation when the KD is missed in childhood. And these patients would then present to cardiologists with acute cardiac event, and we've just talked a lot about that. And we may also have patients who have been transitioned to adult cardiologists and there is a history of KD in them. And these are the ones that we talked about in the previous talk as to how important it is for us to look into their coronary arteries, and their regular follow-up is needed, both with imaging as well as stress tests, and they would eventually require medical and surgical treatments. So this is a paper which Dr. Ankur as well as Dr. Rakesh compiled, and this was a paper on 10 years follow-up in KD in patients who were more than 10 years, and in the initial years we used to miss these smaller children but essentially recognize KD in older patients. And these patients, and at that time we had a median age of much higher than that reported by Japan and Western world. But Dr. Vijay Varghia compiled this paper in which he has put forth 4 patients who had presented with acute cardiac events, one patient requiring a CABG, and they had history of, and in most of these patients there was missing out of the childhood KD illness. So what does this all tell us? It tells us that KD leaves a lasting imprint on coronary arteries, altering them for life. And this is probably the most important message, because as Dr. Burns and Dr. John Gordon have put up, is that once the normal arterial wall architecture has been damaged, the affected segment will always be abnormal and have abnormal characteristics. So this is the impact of KD in patients on coronary arteries. So what does it actually lead to? A typical coronary on healing will have active remodeling as well as intimal proliferation and neoangiogenesis. There'll be myointimal proliferation, there will be disruption of internal elastic lamina, there'll be smooth muscle cell necrosis, and a lot of fibrosis and calcification. So they actually will never be normal again. This is, however, different than atherosclerosis, because in atherosclerosis what we actually find is lipid-laden macrophages and cholesterol crystals, which are conspicuously absent in patients with coronary artery disease secondary to KD. So though premature atherosclerosis is a term very well used in papers, but if you actually look into the pathology, there has to be a differentiation between healing in patients with KD aneurysm and patients who develop atherosclerosis. What happens to patients who have normal echoes? We don't have much pathological data on these patients because of the fact that the initial studies are autopsy-based studies, and you don't expect death in such patients. However, in patients, especially children, especially one such child reported in whom the death in the child was unrelated to KD, they found that even with normal echocardiographies, there were changes in intima of the coronary arteries. There was disruption of internal elastic lamina as well as smooth muscle infiltration. Hence, despite treatment, such changes in the coronary arteries is going to persist. They are also predisposed to endothelial cell dysfunction and arterial wall injury, especially in patients who have persistent coronary artery aneurysms, who have history of even transiently dilated coronary arteries, and even in patients who have angiographically normal appearing coronary arteries. So hence there lies the importance of the fact that even when you do morphologically or anatomically find that these patients are normal, they will actually have endothelial cell dysfunction. So this is just a summary of what I have said today, that there is in coronary arteries, there is proliferation of myofibroblast and smooth muscle necrosis, organization of this thrombus resulting in progressive stenosis. There is endothelial dysfunction, as well as well documented that these patients do not respond with coronary, with dilatation whenever there is myocardial demand which is increasing. So if there is an increase in demand, these coronaries are unable to dilate. There is calcification, we've all talked about it, and there is premature atherosclerosis. Now this is a loosely described term, but there is an evidence of premature atherosclerosis in these patients, and what is most alarming is that there is functional stenosis. Now what do you mean by functional stenosis? Because of fibrosis and calcification, even if the diameters look normal, even if the angiography is normal, the healed coronaries do not behave exactly the same way as a normal coronary would do. So this is what is called as functional stenosis. However, things are not that bad always, because it is very uncommon to see individuals who have thrombosed one or more epicardial arteries to be associated with ischemia and myocardial infarction. In the last two talks, we heard about a lot of talking about everything being bad, patients needing CABGs and interventions, but it is not always that bad because of development of collaterals. And this is auto-bypass. And this auto-bypass is often seen in patients who've had KD at a very young age. So the younger the age at which you develop KD, more are the likelihood of development of collaterals, and these patients, all they require is a careful follow-up and medical management, and they may not actually need a lot of surgical interventions. So we've had a beautiful talk by Dr. Suda, and in fact, standing here after her talk, who has the maximum publications and the data on the effect of cardiovascular outcomes, especially from Osaka, is actually humbling for me, because if you read literature on cardiovascular outcomes, it is essentially her studies that dominate. And we've seen her in previous talks that outcomes of these patients are improving with time as and when the interventions and early recognition of, hence there is a reduction in sudden cardiac deaths. So which patients are at maximal risk of complications? So the maximum complications are seen in patients who have large aneurysms affecting both left and the right coronary arteries. So the mid-term follow-up of a cardiac-free event, that means either defined by death, myocardial infarction or intervention, was only 36% in patients who had bilateral large aneurysms. So bilateral large aneurysms is a risk factor. But is absolute diameter the only predictor of thrombotic risk? No, probably not. Why? because the risk of thrombosis not only is high in patients who have big Z-scores or in adults with an aneurysm, but also important is the fact on the length of the lesion. Long lesions with lesser diameter also predispose patients for thrombosis. Hence, better methods are needed to assess the hemodynamic impact of these aneurysms. And as you all are very well aware, long ectatic segments in RCA are also associated with, of a normal size, are also associated with greater risks of thrombosis. And this is essentially because of various hemodynamic changes that occur as the length of the involved segment increases. So when children with Kawasaki disease grow up, another group which is really interested is Dr. Jane Burns' group and her husband, Dr. John Gordon, and they have published a lot of literature again on how these children with KD behave once they grow up. And they have, in this study, they have suggested that despite having normal coronary arteries, during acute and subacute phase, young adults with history of Kawasaki disease with normal coronaries were more likely to experience palpitations, they were more likely to experience leg pain with walking, more chances of chest pain, and of course, hypertension and migrainous headaches. So patients who've had KD have, even with normal coronaries, have problems in young adulthood. This is the most latest paper on a systematic review on long-term cardiac and non-cardiac prognosis in KD. And in this review, the outcome measures were all causes of mortality, major cardiac events, chronic cardiac disease, and non-cardiac disease also. And in this meta-analysis, in the systematic review, they found they actually eventually included 74 high-quality studies for further analysis. And what they found was that in most patients who've had KD, the survival is very good, up to 90%. However, patients with coronary artery disease and with giant coronary arteries, you can see a drop in survival over a period of time. You can also see that the upper line here, actually the yellow line, this is the medium coronary medium CCAs, and this one is the patients with unspecified coronary artery aneurysms, and you can see how early deaths can be seen in patients with giant coronary arteries. They also found that in these studies, 9 studies, there was 10 studies reported hypertension, but hypertension did not turn out to be an important final outcome, finally did not turn out to be a risk factor. Presence of KD did not turn out to be a final risk factor for hypertension. There was some evidence for hyperlipidemia, but there was definite evidence of it being a risk factor for premature atherosclerosis. Among the non-cardiac diseases, and this is something that actually attracted my attention, was the fact that patients with KD had a very high incidence of allergic diseases. So what does, apart from moving on from coronaries, which always take a precedence in Kawasaki disease, there are other 3 areas where long-term effects can be seen, and the other is the myocardium, the valves, and the systemic arteries. So myocarditis is almost universal in all patients with KD, and diffuse myocarditis is followed by myocardial fibrosis. Now, this myocardial fibrosis eventually results in both systolic and diastolic dysfunction, resulting in decreased ventricular contractility. This myocarditis contributes to the late onset arrhythmias, as we were talking previously. This myocarditis contributes to congestive cardiac failure and sudden deaths, essentially because of ventricular arrhythmias. So what is needed is the fact that we recognize myocarditis in these patients, and smoldering inflammation of the arterial wall and the myocardium, which may remain clinically silent, should be recognized early. The valves. So 2% of patients with KD will develop valvulitis. This is followed by scarring of the valve leaflets. Most commonly involved valve is the mitral valve, resulting in valvular incompetence, and valvular incompetence again results in decreased cardiac output. What is also important is the aortic valve, and a progressive aortic dilatation, root dilatation, is seen in patients with Kawasaki disease, and there were significantly higher aortic roots when in a longitudinal study in patients with KD. So mild aortic valve regurgitation was noted at 1 year visit in 4% of KD patients with Kawasaki disease. So if the third component is the aneurysms in systemic other arteries, and among the other arteries it is the axillary artery, the iliac artery, and the common femoral artery, which is important. These lesions are essentially symmetric, but patients can present with claudications and weakness in extremities. So aneurysms in systemic arteries is also an important thing that we have to keep in mind in following up of these patients. Other non-cardiac features is the elevated levels of LDL, which may contribute to clinical presentations of acute coronary artery syndrome or non-coronary artery syndrome manifestations, especially because of increasing the risk of atherosclerosis. So just to conclude, the impact of KD on cardiovascular health can be profound. Today, we should all attempt for early diagnosis, prompt and appropriate treatment, give focus on follow-up of cardiac care and timely cardiac interventions to protect these young hearts from developing this really profound effect on their health. Thank you.
Thank you, ma'am. That was an excellent talk, very informative. Any questions or comments from the floor?
Thank you.
This aortic root dilatation and aortic regurgitation is how significant it is on the follow-up. And because we routinely do not look into this, at least when I see them on the long run, I do not. Maybe from today I will look into that as well.
So this was in the literature search that this was mentioned that apart from coronaries, one should also look at the aortic root dilatation. But I would not know the exact figure of how many patients. This was a longitudinal study of 100 children that in whom they found that the aortic root was definitely dilated in these patients over a period of time. But maybe we can ask Dr. Suda as to how.
Vasculitis involves non-major arteries, right, as a basic fact of Kawasaki disease. Aorta is a larger or the largest.
The question is regarding aortic root or aorta involvement in Kawasaki disease. How commonly used?
Rare.
Case was reported.
Thank you.
So aortic root dilatation is seen in 10% if the age statement has been reported. And we have done a CT angiography in one patient with giant aneurysm to found that because there was a suspicion of the peripheral aneurysm, and in there aorta is hugely dilated. So because that there was a giant aneurysm, so it has been reported aortic root dilatation is, as per AHA scientific statement studies, 10% of the patients can have aortic, and there are G scores also for aortic root dilatation.
So, and then is it common in some subsets like GIAN coronary or
Possibly.
or
Possibly with more severe disease. That is.
Over the long-term thing, there is one thing about the association of malignancies with patients with Kawasaki, and yes, as you have pointed out from the systematic review about the allergic disorders in association with Kawasaki disease. So, I want to have ma'am's experience about this malignancies with Kawasaki disease. Right.
So in the systematic review, there was one paper which has talked about malignancy as, but just as an association, not as a, yeah. Yes, ma'am.
You mentioned in one of the slides that even KD children with normal coronaries may get on some problems, whereas the rest of the talks, the lady said that they should be followed up to 1 year and there should not be any problem. Can you elaborate on that?
So, ma'am, in terms of development of cardiac complication, they are less likely to develop any such problems. But in terms of consequences of health, in terms of other health consequences, they found in these studies, long-term studies, there are at least one from Taiwan, one from Malaysia. They found that other health problems can also be there in these patients, especially allergies. There is mention of depression, there's ADHD, and those things are also there. So, but then that can be how much happens in the normal population as well as how much happens in normal population, that needs to be seen.
Even with reference to the cardiac or coronary involvement, ma'am has mentioned, and I also mentioned in one of the slides, pathologically, there is always involvement of the media as well as intima in terms of thickening, smooth muscle proliferation, and the lack of adequate response to the coronary vasculitis. That means there is involvement even in the long run that may not clinically manifest if it is a regress aneurysm or no aneurysms at the time of diagnosis. That does not mean pathologically they are not involved, may not be clinically relevant at this particular point of time. And once our understanding further improves, and if we follow them still longer, we might. So it's always better to assess clinically once in 5 years. I think that's how we should follow this.
Dilatation, you do see hyperintensities and without aneurysm in dilatation, the layer, the intima, that is quite hyperintense.
Bright.
It means that is involved in the dilatation. That's what you know.
I don't think we can so clearly tell on echo whether it is hyper intense, rather hyper echogenic or what.
It was
so
in few of our cases. It was echogenic. It was very bright. The corners were dilated. No aneurysm, but brightness.
So I would diagnose it as a layered thrombus if it is hyper-echogenic on transthoracic echo and take help of the CT for that. If I find any hyper-echogenic layer in the dilated coronary segment. So by echo, at least for me, it is difficult to say whether it is intima thickening or the wall is thickened or there is a layered thrombus. Certain thrombus versus intimal thickening of the endothelium or the coronary.
Intimal thickening might be very difficult to say on CT thrombus, yes.
That's all. If I find such things, I take help of the CT to see whether it is thrombus. It's almost always seen in the giant aneurysms, and it's there almost always on the anticoagulation. From management perspective, it's not going to make any difference unless significant lumen is involved. And in that case, there will be either symptomatic or there will be evidence of ventricular dysfunction if there is associated obstruction. And the management will be according to those lines. Thank you.
Thank you. Thank you.
Thank you, ma'am, for the talk. Now, for the next session, I would like to invite Dr. Rakesh Plania, sir, to chair the session.
So after this, we'll go on to the therapeutics of PAD again, and for this I would invite Dr. Sanjay Suleria, alumnus and my senior. So he's an assistant professor and pediatric immunology and rheumatology, resident in the Department of Pediatrics, and he has over more than 60 publications in national and national level. So sir is speaking on treatment of cardiac disease. What is the standard treatment in 2024? Sir.
Thank you, sir. First of all, thank you organizers for giving me this opportunity. And I would be talking about treatment of Kawasaki disease. As we all know, Kawasaki disease is a common childhood vasculitis, and it is the common cause of acquired heart disease in children in developed countries. One of the serious complications of this disease is development of coronary artery aneurysms, which is seen in nearly 1/4 of untreated patients. But there is effective treatment, and it can reduce the occurrence of this complication by more than 6-fold. For treatment purpose, we usually divide patient into two groups. One is low risk group and second is high risk group. And division into high risk group is based on some risk scores like Harada risk score for coronary artery aneurysms given in Japan, then Kobayashi score, Igami score, Sano scores used in IVIG residents. This is one of the score given by Son et al. And it has been developed and validated in North American population. But when these scores are used in different population group, they have limited utility. In treatment in low risk group, we primarily use IVIG and aspirin. Whereas in high risk group, in addition to IVIG and aspirin, we use second line therapy, corticosteroid, infliximab or cyclosporin. Now I would be talking about treatment in low risk group, whereas Dr. Avesh Shivpuri will subsequently talk about treatment in high risk group. So we know that Kawasaki disease was first described by Dr. Tomisaki Kawasaki in Japan in 1967. And after that, aspirin and prednisolone were standard of care. Then there was a study by Kato et al. In 1979, and there were also other studies which have shown the effectiveness of aspirin in reducing the incidence of coronary artery aneurysms. But these studies also showed that corticosteroids paradoxically increase the incidence of coronary artery aneurysms in these patients. So after these studies, the use of corticosteroids in Kawasaki disease was stopped. Then there was a multi-center controlled trial in 1984 by Firoshow et al. They compared aspirin with aspirin plus IVIG. IVIG in a dose of 400 mg per kg per day for 5 days, and it was the dose of IVIG that was used for ITP at that time. And they showed that IVIG significantly reduces the frequency of coronary artery aneurysms in patients with KD. So after this, the use of IVIG in KD came into practice. Then there were other studies, ongoing research on the optimization, frequency and timing of IVIG. This was a pilot study published by Engel et al. In 1989, in which they compared 1 gram per kg single dose IVIG with multiple small doses, and showed that 1 gram per kg single dose is more effective than the multiple doses in treating the patients of Kawasaki disease. Then this is a landmark trial published in 1991 in NAGM by Neuberger et al. And they showed that single dose of 2 gram per kg IVIG with aspirin is more effective in treating KD than multiple small doses. And after that, the 2 gram per kg IVIG is standard of care in patients in KD. So in primary treatment, we use IVIG 2 gram per kg over 12 to 24 hours, and it should preferably be given within first 10 days of illness. And if patient is diagnosed after 10 days, then we give IVIG. If child is still febrile, he or she has elevated inflammatory parameters, there is coronary artery dilatation, or sometime after counseling the parents on their discretion. And if the child has coronary artery aneurysm, we use additional anti-inflammatory therapy. So what does American Heart Association says on the use of IVIG in Kawasaki disease? This is 2024 update on diagnosis and management of KD. As per it, IVIG at 2 gram per kg infused over 8 to 12 hours remains the standard of care. IVIG is generally well tolerated. Hemolytic anemia is dose-dependent complication of IVIG. There are various studies which have shown various factors associated with hemolytic anemia when we use IVIG. One is the dose of IVIG. Higher the dose of IVIG, more the chances of hemolytic anemia. Then the degree of inflammation. Higher the inflammatory parameters in a child, more the chances of hemolytic anemia. Third is blood group. It is more often seen in blood group AB positivity, followed by A group, B group, and not seen in O group. Then obesity is another risk factor for hemolysis if we use IVIG. So dosing for IVIG should be based on lean body mass. Aseptic meningitis is another complication, but it is transient and without sequelae. So what is the future trend? We know that the etiology of Kawasaki disease is still not clear, and it is thought to be some environmental trigger in genetically predisposed individual. Also, we see heterogeneity. Some patient may have severe form of Kawasaki disease, some may not have. Some may develop coronary artery aneurysms and other may not. So if we think logically, ideally there should not be some blanket cover for treatment like 2 gram per kg of IVIG in every patient. It should be some targeted therapy based on the clinical and disease profile of the patient. This is one study by Suzuki et al. It is a retrospective analysis in Japan in which they compared 2 gram per kg IVIG single dose with 1 gram per kg IVIG in children more than 25 kg. And they found no significant difference in outcomes in terms of coronary artery aneurysms, IVIG resistance, or adverse effect. This is another multi-center open-label trial in China, in which they studied 404 children, and they divided these children into 3 groups. Group A received 2 gram per kg single dose, Group B received 1 gram per kg for 2 consecutive days, and Group C 1 gram per kg once, and all these 3 groups received aspirin 30 mg per kg per day. And they found no significant difference in outcomes of defervescence at 6, 12, 24, and 36 hours. And there was no difference in the incidence of coronary artery aneurysms in all these 3 groups. Then another study was Matsura et al. In Japan, in which they studied 277 patients, and they divided these children into 3 groups based on Kobayashi score and less high risk score. High risk score have Kobayashi score more than 5 points, and they received 2 gram per kg of IVIG single dose with prednisolone. And moderate risk group with Kobayashi score of less than 5 and less high risk score more than or equal to 2 points received 2 gram per kg IVIG, and third group, which is low risk group with Kobayashi score and less high risk score less than 2, received 1 gram per kg IVIG. And there was no significant difference between the groups regarding treatment response to coronary artery aneurysms. And they concluded that stratified therapies for patients with KD based on the scoring system may be useful. Aspirin is the second drug used in KD, and this study I have shown earlier. It was Kato et al. Who showed effectiveness of aspirin in reducing the incidence of coronary artery aneurysms. So this was a study by Yokoyama et al. Published in 1980. They compared effectiveness of moderate dose, that is 30 mg per kg per day, to the high dose, and showed that the moderate dose is as effective as high dose in treating KD patients. Then this is a meta-analysis published in 1995. They had 6 groups. First is the group of patients who received only aspirin. Second group, low IVIG with aspirin, then third, high IVIG with aspirin, single IVIG with aspirin, high IVIG and low aspirin and so on. And they found that the incidence of coronary artery aneurysms both at 30 and 60 days after was significantly lower in low IVIG than in aspirin, which means low IVIG was more effective than aspirin alone, then high IVIG than in low IVIG group, which means high IVIG is more effective than IVIG, low IVIG. And there was no statistically significant difference in the incidence of coronary artery aneurysms in high IVIG, low aspirin and high IVIG, high aspirin group, which means there is hardly any difference in the effectiveness of aspirin in low dose or high dose when used with IVIG. This is a study from China on nearly 1,000 children in which they compared no or low dose with moderate dose and found that moderate dose aspirin demonstrated no benefit with regards to anti-inflammatory effects, and the aspirin dose had no relationship with the formation of coronary artery lesions. This is a systematic review published in 2024. Again, they compared no or low dose versus high dose aspirin, and they found that there is no significant difference in no or low dose aspirin versus high dose aspirin in the incidence of coronary artery aneurysms, IVIG resistance, fever duration, and overall hospital stay length. So aspirin we use for its anti-inflammatory and antiplatelet effect. Initially we give 30 to 50 mg per kg per day, 6 hourly till child is febrile for 2 days, and then we shift him on to 3 to 5 mg per kg per day aspirin, and we continue it till 6 weeks, and if echo is normal at 6 weeks, we stop it there. So what AHA says about use of aspirin in Kawasaki disease, this is again 2024 update. As per it, aspirin is used in moderate or high dose until the patient is febrile for 48 to 72 hours. Then low dose aspirin after defervescence and continue it till 6 to 8 weeks after onset of illness. And there is increasing evidence that medium or high dose aspirin in acute phase is likely not associated with improved coronary artery outcome. And there are several retrospective cohort studies which have shown no difference in coronary artery aneurysm rate between patients who were treated with moderate as compared to high dose aspirin. So this is ongoing multi-center prospective randomized trial in China with a sample size of 1,346 participants, and they are comparing IVIG 2 gram per kg plus moderate dose aspirin, that is 30 to 50 milligram per kg per day, to IVIG plus low dose aspirin, that is 3 to 5 mg per kg per day, and the results are still awaited. So these are the other drugs used in long-term prophylaxis, and these have been covered in previous talks. And for antiplatelet effects, there is a recommendation for using dual therapy in medium and large aneurysm. For dual therapy, in addition to aspirin, we use dipyridamole and clopidogrel. And in anticoagulation, we use heparin in younger children and warfarin in older children. And also the direct-acting oral anticoagulants have shown promising results. Statins for their anti-inflammatory, antioxidation, antiplatelet, antithrombotic, antilipid effects are used if the child has aneurysm, and beta blockers are used in case of child with large aneurysms. So to conclude, IVIG at 2 gram per kg remains the standard of care. Aspirin we use in moderate dose until the patient is febrile for 48 hours, then we use low dose aspirin. There is increasing evidence that medium or high dose aspirin in the acute phase is likely not associated with improved outcome, and targeted therapy based on clinical disease and genetical profile is the future. Thank you.
Thank you, sir, for such a topic. And you have covered regarding the what is in future regarding the role of IVIG and aspirin and how dosing and all these things also. So we'll take questions after Dr. Abhay's talk also, because he will be speaking on the treatment of AD when there is an IVIG refractoriness. So Dr. Abhay is a pediatric a rheumatologist at New Clinic Children's Hospital in Jaipur, and he is practicing rheumatologist, pediatric rheumatologist for the last 5 years.
Thank you. I would like to thank Dr. Surjit Singh sir and Dr. Rakesh for inviting me for the talk. Yesterday I was just speaking to Deepthi ma'am regarding the fact that I was here for a few months in 2015 when I was planning to start pediatric. I was thinking about doing pediatric rheumatology, and it is a bit nostalgic that I came back 10 years later for a Kawasaki conference to the same center. So I'm grateful to the organizers for this opportunity. As Dr. Sandesh mentioned, the low risk category for management of Kawasaki, I know most of it is, some of it is repetition and overlap. I also got to know that the next speaker is also speaking about primary intensification, Dr. Aparna, so we'll cut short on that part and we'll skip on those slides. But what we want to know is who is at high risk of coronary aneurysms and IVIG resistance. So I'll give you 2 case scenarios, and it is quite obvious if you see the case scenario 2 and 1. So looking at scenario 1 is an infant male with fever for 10 days, irritability, basically edema of hands and feet, unresponsive to antibiotics, incomplete disease, and high WBC count, neutrophilic leukocytosis, high ESR, high CRP, with 6 to 7 pus cells, low sodium, blood and urine cultures negative, and echo showing a positive Z-score of 4.6 LAD. And if you look at the case scenario 2, which is the more commonly seen case scenario across pediatricians, this is a case of a classical Kawasaki disease with a normal echo Z-score. So it is not too difficult in such a story to say that this case scenario 1 is the one at the higher risk. So what are the red flags in case scenario 1? So it would be the age and sex of the child, incomplete Kawasaki disease, delay in diagnosis, coronary artery at presentation, aneurysms, and high Kobayashi score. So all of these actually are red flags in scenario 1, and that often leads to a delay in diagnosis and hence the complications. So if we simplify these steps, if it is low risk, we would treat KD as discussed by Dr. Goleria sir. And what is more important now is how to identify who are the children at high risk. Then comes the need for primary intensification, and then what happens if the child does not respond to the IVIG is when we call it resistant disease. On an average, 10 to 20% of them may not respond, but there's different data across different studies, which this study mentions about 7.5 to 26% of resistance, and what are the treatment options. That is what we will be trying to discuss. Now, we all know that there are some risk scores from the Japanese population, and the components, the commonly used one is the Kobayashi score, but the other scores are called as the Igami and the Sano score. What are the components of these scoring? From CRP, age, days of illness at Kawasaki disease diagnosis, AST, sodium, percentage of neutrophils, and platelet count is what constitutes Kobayashi score. If you look at the center table here, sodium of less than 133, a day at illness of treatment less than 4 days, AST of more than 100, more than 80% neutrophils, and a high CRP, infant less than one year of age, and a low platelet count is what constitutes a high Kobayashi score. Normally we say 4 or more or 5 or more are the children who are at a higher risk of IVIG resistance. So this study was published in 2006. There is some problem with my font, so I'll apologize for that. This study was from 2006, in which occurrence of IVIG non-response obviously keeps increasing as the risk score of Kobayashi and the components keep increasing. This graph shows about the coronary artery abnormalities that also keep increasing as the high risk children become more high risk and a score of more than 5. But of course, this was studied in the Japanese population. So what data do we have on other ethnicities? So in 2020, there was a KAVA-NET study, which was the French cohort. And what variables did they look at? That was the ALT value, hepatomegaly, lymphopenia, and the time to treatment. So this is in the non-Asian children, but a French cohort. Sun score, which Dr. Guleria also mentioned, actually is the North American cohort, in which they have looked at components such as age less than 6 months, Asian race, coronary artery Z scores more than 2 on the initial echo, and a high CRP. And a score of 3 or more is predictive of a coronary artery aneurysm. So I was speaking to Dr. Priyankar Pal sir from Calcutta, and they had published this study in 2022. And they have proposed an Indian scoring system for a high risk of Kawasaki. basically we'll realize that there are so many components of different scoring system across different ethnicities, but what is most important is that there is a commonality between them, and we just have to identify who are the children at high risk, and those need to be intensified for treatment. So if we look at the scoring proposed by the Calcutta team, the training data set contained of 70 patients, and out of which 24 were IVIG resistant, and the testing data set for the training data set had 45 patients, and the IVIG resistance was in around 15% of them. So basically it's very similar to Kobayashi's score. What the changes are highlighted in red. On the left hand side is the proposed score, and on the right hand side is the original score. Sorry for the font issues. Left is the proposed score. So age less than 21 months, CRP more than 17, and a platelet less than 6 lakhs. So how did these numbers come? This is of course by the statistics, and what it has led to is basically an increased sensitivity. So if we see the original score, the sensitivity was 0.66, and in the new score, proposed score, it can go up to 0.8. But there are some limitations, of course, of a new proposed scoring system. One is that it does not take into consideration about the progressive coronary arteries which may progress after the IVIG infusion. This is mainly talking about IVIG resistance. Second is this is a single center study, so we need more centers to be involved across India to be able to actually say that this is actually, this sensitivity is actually true for across populations in India. And this was the latest study in 2025 in which they have looked at 14 cohort studies and looked at 6 variables. So male sex, age less than 12 months, rash, cervical lymphadenopathy, high neutrophil count and a low platelet count. And higher the score, the greater the possibility of additional treatment. This study is from China but published in the Italian Journal of Pediatrics. And the proportion of resistance in this study was ranging between 5 to 24%. So that's what I was saying. So basically we have to look at some of the components. The common components, there are quite a lot of them. Looking at the infant or not, and the bloods we've talked about high or low platelets, high CRP, male sex, cervical lymph nodes, late administration or early administration of IVIG, if the child was already IVIG resistant, delay in diagnosis, MAS or KD shock syndrome, and increased baseline coronary Z score. So these are some of the factors which will lead to which will either need primary intensification or may lead to resistance also. So this was a paper published in 2024 by the PGI team, Dr. Burman, and it really beautifully gives you a timeline of events. That in 1979 was when the famous study of Kato et al. Was published, in which after which the favor moved away from steroids because of the thought that steroids actually harms the children with Kawasaki disease. And after the use of IVIG, as Dr. Sandesh has nicely pointed out, we moved towards IVIG and aspirin, and over time we realized the risk factors which led to more primary intensification with different options for treatment. I think Dr. Abarna will be covering those, so I'll skip those parts. So, and then since use of IVIG, there were multiple studies on steroids and the use of benefit of steroids in Kawasaki. Yesterday, Dr. Tapas sir has also beautifully summarized all the studies. It meant that single pulse steroid is not effective, but you can either use 3 pulse steroids or you can use IV methylpredate at 2 mg per kg per day. They also looked at the cytokine levels in IVIG plus steroids and without steroids, and all these were in favor of steroids. Till there's of course a RAISE study, which is a landmark trial published in the Lancet in 2012, which talks about the benefit of coronary aneurysms in IVIG plus steroids. These are more recent papers in initial corticosteroid treatment in Kawasaki, and one of the studies published this month in March 25 from Japan also talks about, can we reduce the steroids earlier? Normally we give it for a period of 2 to 3 weeks. In this study published, they tried to reduce the steroids in a 1 week span. But of course we need bigger studies. This was the Cochrane data, which was also discussed by Dr. Tapas Subui sir yesterday. And basically again, in short, it talks about the fact that we can use steroids as primary intensification. And I'll skip this part. These are more recent studies about intensification. I think I'll skip the part because the next talk is also on the intensification part. This is one of the ongoing trials in UK called the KD-CAP study. This is by the Great Ormond Street Hospital team, in which they are comparing IVIG plus steroids and aspirin versus without steroids. They do not have the results yet, but they'll be out very soon. So how do we define IVIG resistance? So some of the points I've discussed actually is regarding steroids and IVIG. There's a lot of data to use that in primary intensification, but the definition of resistance also keeps changing across different guidelines. So if we see, it basically ranges from 24 to 48 hours after the completion of first IVIG dose. So the American Heart Association and the 2021 ACR Foundation guidelines say that persistence or recrudescence of fever after 36 hours of completion of IVIG should be defined as resistance. The SHARE guidelines 2019 from Europe also say that it should be defined after 48 hours of receiving IVIG. In Japanese guidelines, there's responsiveness is between 24 to 36 hours. In my personal practice, I follow 36 hours. I do not know if anyone else is following 24 hours as cutoff. Dr. Rakesh, are you following 24 hours or is it 36 hours or is it not defined? So it varies across different centers. We can discuss it at the end of the talk. So what is the evidence regarding other treatment options? We've spoken about steroids, but let's see what are the other options. For example, TNFi, infliximab, etanercept, cyclosporin, anakinra, and tocilizumab. Regarding infliximab, there was a trial called as the KidCare trial in 2021, in which they have compared infliximab versus the second IVIG for children who are resistant to Kawasaki disease. And in the infliximab group, there were fewer days of fever, less need of additional therapy, less severe anemia, and fewer severe adverse effects. But there was no obvious difference between the lab marker, resolution of lab markers and the coronary artery outcomes. In the IVIG group, the prolonged hospitalization was attributed to the fact that the IVIG will be given over a longer duration. Primary intensification part with infliximab was also published in 2023, in which they have used a higher dose. Between 5 and 10, we normally suppose we can use infliximab, and there was intensification in inflix was associated with greater likelihood of regression within 2 months compared with IVIG alone. This was another recent study on infliximab for resistant Kawasaki disease. Infliximab is an effective, safe treatment for children with refractory Kawasaki, but has limited efficacy to IVIG for the initial treatment of Kawasaki disease. There's also a lot of studies on the role of IL-1 expression in the children with aggressive Kawasaki disease or severe Kawasaki disease or coronary aneurysms. So they have also done a trial in France called as the Kawa-Kinra trial, in which they've looked at anakinra role for resistant Kawasaki disease. So the doses were between 2 and 6, an average of 4 mg per kg per day of anakinra. And this was given for a duration of 14 days. They've studied this on 16 patients. It does have some role. It was well tolerated, but we do not know for sure that does it help in reducing the coronary artery dilatation. This particular study say that it may have some efficacy in reducing fever and markers of systemic inflammation and coronary dilatation in refractory cases. Data on tocilizumab in resistant Kawasaki disease comes from China. There was this study in which they have included 5 patients only, but they have tried tocilizumab in cases of high Kobayashi score and in those patients in whom IVIG and steroids were ineffective. So tocilizumab effectively controls inflammation and improves coronary outcome, but because it had only 5 patients, we still need more studies to confirm this. Cyclosporin is a well-used drug for patients with Kawasaki disease, and the KAIKA trial was published, and they have seen, this is from Japan, between 2014 to 2016, including 22 hospitals, and basically combining therapy with IVIG and cyclosporin was safe and effective with a favorable outcome. There were more studies in 2023 January which showed similar clinical outcomes regarding the risk of aneurysm IVIG resistance in those children with IVIG and cyclosporin. So what do the current guidelines say? In Japanese, the guidelines talk about IVIG plus prednisolone or IVIG plus cyclosporin. The American Heart Association talks about steroids with infliximab or etanercept. The SHARE guidelines from Europe talk about steroids in severe cases or a high Kobayashi score. The ACR guidelines talk about the SUN score, in which the age of less than 6 months or a baseline Z score high, that is when they can use steroids plus IVIG or IVIG with other immunomodulators. These are some of the features when they have described about using steroids in patients with severe Kawasaki disease. Basically, when they have high Kobayashi score, features of HLH, features of shock, less than the age of 1, what they have given for the steroid regimen are two regimens. One is methylpred 0.8 mg per kg BD, and second is a pulse steroid 10 to 30 mg per kg per day. And the other options are usually used for resistant disease. So the American Heart Association talks about IVIG and aspirin for initial treatment. For intensification, like we discussed, the options are usually around steroids and TNF blockers. And for resistant disease, we can use cyclosporin, anakinra, second dose of IVIG, or cyclophosphamide. This was published in 2022 by Surjit Singh sir and the Indian Academy of Pediatrics standard treatment guidelines. And this also talks about the fact that we can go beyond IVIG. We can use oral prednisolone 2 mg per kg until afebrile or CRP normalized, or you can see all the different options: IV methylpred or infliximab or cyclosporin or anakinra for resistant diseases. And this is a paper recently published, which I showed with the timeline initially, which talks about the intensification and the treatment options we have. And basically, these are all the high-risk children we discussed, and in those cases you would intensify, and there are options of again IVIG, steroids, TNF blockers and cyclosporin, and in some children we may need more options together. So to conclude my talk, basically we have to identify who are the children at high risk. I'm sure we've already discussed some of these in the last few days, but we have to identify who are the high risk of IVIG resistance and coronary artery abnormalities. We have to think early of primary intensification, as across the last few days we have seen multiple studies of the long-term sequelae of the coronary arteries if not picked up on time. And of course we have looked at the different treatment options for resistant disease. Thank you.
Thank you, Dr. Amit, for nice talk. So basically both talks regarding the standard treatment and treatment for IVIG effectiveness is open for comments and questions. And before that, I just comment that I'm asked that IVIG induced hemolysis during the acute phase of the treatment, because that is a very big concern, especially in the reported in the West Americans has reported statement. And second is regarding the dose of aspirin, so which is like again something which is evolving, and possibly now more and more people are started using antiplatelet dose during the febrile during the acute phase only. So, Dr. Sandesh.
As per literature, the incidence of hemolysis in KD when used IVIG is 0.6 to 16%. And there are various factors on which it depends. Another factor is brand of IVIG. Generally acceptable antibody titer against RBC is 1 to 64. And if we use multiple doses of IVIG, higher doses of IVIG, the risk of hemolysis is low. And other factors I have highlighted are blood group, then obesity is another factor. Regarding use of aspirin in Kawasaki disease, as per literature, there is no additional benefit of using high dose or moderate dose as compared to low when we use it with IVIG. And there is ongoing trial in China in which they are comparing low dose with high dose. The results are still awaited. But it is basically, I think, practice-based, not evidence-based.
And the second question which Dr. Abhay has also put is the definition of IVIG resistance. In a clinical bedside, when we are seeing a patient, it's always difficult to put a definition that 24 hours, 36 hours or 48 hours, because like now fever can be because of several reasons, and we have to rule out possibly several causes, and these definitions are possibly just and we can categorize the patients as IVIG resistance. Again, like now, how people are using these definitions, and more so like when we are doing treatment intensification, which Avarna will be talking about that. Like the definition of IVIG resistance would be again this would be a blurring, because how you would intensify based on the several things, and then whether you would call as IVIG resistance or not, refractory disease or not, that is again an issue. So Murugan, how would you treat patients with IVIG refractoriness or resistance in your center?
36 hours.
36 hours, which is AHA.
So actually this definition of resistance, we should not only consider the persistence of fever at the 36 hours. Even worsening aneurysm at the end of first IVIG can also be considered as IVIG resistance. But nowadays the concept is fading away because of the intensification.
So, I'll just add one comment. So, in Dr. Paul Brogan from Great Ormond Street actually always talks about the fact that you have to make sure that there is no fever, the CRP normalizes to 0, 0 as a negative, and the coronary is stabilized. Until then, you have to keep intensifying. Otherwise, like Murugan also mentioned, it is not just the fever, we have to look at the whole picture.
So that's what the problem with definitions are, that if you just follow strictly the definitions, then it would be and you would rather over treating or mostly under treating these. Maybe you would want to ask anything?
As far as our center is concerned, we have been using 3 to 5 mg per kg cardiovascular in all KD right from the onset for the past couple of years at least. Secondly, when we are talking about refractoriness, one practical difficulty which we also face is that in how many patients we are actually able to complete IVIG total dose in 12 hours as recommended by the AHA. It is not very often that we are able to give all that much in 12 hours itself, so that is one another practical problem we face. And third, we're seeing that the rates of hemolysis are also linked to obesity. So I assume that is because in the obese children the dose of IVIG we are giving is higher.
Yeah, possibly that one.
Definitely the studies have shown that higher the dose, more the chances of. And if we take total weight in case of obese diet, we definitely giving higher dose. So it should be based on the lean body mass instead of total weight in obesity.
There are no more questions. Thank you, Dr. Sandesh and Dr. Again.
I think since morning what we have been discussing is how to fine-tune the treatment of Kawasaki disease. So 20 years ago, all children with KD received the same treatment, which was IVIG 2 gram per kg. But what has now emerged all over the world is that you have to be far, far more aggressive, and aggressive from the word go, preemptively. And it is these subsets of Kawasaki disease that you need to identify. So for all the residents, I would recommend the article by Dr. Jane Burns, in which she has categorized 4 subgroups, well-recognized subgroups of Kawasaki disease. So once you identify a subgroup which requires aggressive treatment, you have to start the treatment early. So the next few talks are basically on how to identify these subgroups. So we start with the first talk, which will be given by Dr. Abarna. Abarna is an alumnus from this institute, and she's now based in Chennai. So she will be talking on treatment intensification in KD in various situations.
Good morning everyone. It's good to be back after 2 months. Intensification in Kawasaki disease, when, why and how. So most of my talk was covered by the previous 2 talks, but it's okay, I'll try to say things that has not been covered in the previous talks. So we all know Kawasaki disease is a self-limiting disease, and the main issue is the coronary artery abnormalities. And pre-IVAG, we know without treatment, the incidence of CA is around 25%, and with IVAG, it reduces to nearly 5%. So the question is like, does it really reduces to less than 5% in all subgroup of patient or all patient? If we subgroup analysis, the patients who are at high risk, is it always like less than 5%? So that is when we think about this, then primary intensification comes. So there are like a lot of risk factors based on the area in which the person is from, like US says like different scores and Japan says like different scores, so it varies with topography. There is no standardized risk factor or a scoring system. It varies in the different parts of the world, and the risk factor differs from other countries, especially Japan and India and US and everything. So this is the case that I managed in my last month of SRship, like few months ago. So this is a 3-month-old case who came after vaccination. She had fever for 5 days, she had rash, she had conjunctival injection, lip redness and oral mucosal changes, but in the private practice, the child was only treated with oral cefixime. But later child came with a gangrene and a well-defined rash and peeling. So during the time of admission, we noticed the child had GIAN coronary aneurysm involving LMCA, LAD, LCX and RCA. So in this patient also underwent a CTCA, which is I have depicted in that slide. So this child had like 2 aneurysms in the LADs and had a giant aneurysm in LCX and an aneurysm in RCA also. So this case, if we see, this child was 3-month-old, so that is also a risk factor, diagnosed late, the IVIG was started late, and in the day of presentation only child had like giant aneurysms. So all these risk factors child had when the child presented with this. So the potential risk factors for CA in KD, so that is when we start with the intensification. So when it's a refractory disease or like resistance, that is like you are reacting later, but like sir told, like preemptively we have to find out what are the risk factors. So these are the like few common risk factors that has been covered in the previous talks also. One is like age being less than 1 year. One is the gender, a male gender or prolonged duration of fever, delayed initiation of IVIG, IVIG resistant KD or coronary artery aneurysms, or Z scores more than 2.5 at baseline. So I will be talking about the few studies that highlights these risk factors. So first, age is a risk factor. We all know both in the lesser age group and those in the older age group, both are at risk of developing CAS. So first, Salgado et al. Has studied infants less than 6 months, and he found out like the rate of coronary artery aneurysm is almost as high as like 40%. And there was one more study by GIAN et al. He also studied children who are less than 88 months of age, and they have found that the aneurysm rates are almost around 47.4%. So these are the two, this is one of the group that is age infants, that is less than 1 year. Few says like less than 6 months, few says less than 8 months, and different studies says different age group, but definitely a less than 1 year is a risk factors for developing coronary artery aneurysms. So I have not highlighted one of the article that is from our institute regarding the older age group. I think Deepti ma'am has highlighted that article. So in that study, in the older age group, they have mentioned like coronary artery aneurysms almost around 15%. Coming to the next thing, that there are scoring systems like Kobayashi score, which says IVIG resistant. This scoring system does not predict the risk of coronary artery abnormality, but predict the risk of IVIG resistance. So we always say like when there is an IVIG resistant, there is an increased risk of coronary artery abnormality. But nowadays there are studies which are coming up which says like try to predict the scoring system for coronary artery abnormality, which I will be discussing in the subsequent slides. So these are studies from various parts of the world which talks about the coronary artery abnormality, the risk factors for coronary artery abnormality. So there are few factors which are common, including the duration of fever, that is like more than 6 days, few says more than 10 days, and definitely age, like I said, less than 1 year is a risk factor, and also the higher the age group is also a risk factor. The day of IVIG infusion, the delay in the IVIG infusion, definitely the increased risk of coronary artery abnormalities. And hemoglobin less than 10 has been found to be a risk factor for giant coronary artery abnormalities. Thrombocytosis, that has been mentioned in studies from Croatia and Spain, being a high risk factors. IVIG resistant refractory diseases, recurrent diseases, coronary artery aneurysm diagnosis, atypical KD. So all these are the risk factors that they have mentioned. So this is from post-RISE trial. So in which they have mentioned like independent predictor for coronary artery abnormality, they mentioned like 3 factors. The one is like the baseline Z-scores being more than 2.5, age of onset being less than 1 year, and non-responsive to IVIG plus steroids. The significant independent risk factor for IVIG resistance are the Kobayashi score and baseline total high bilirubin levels. So these are the independent risk factors that they have mentioned for the development of CAAs and IVIG resistance. So this is the SUN score, I think, which has been covered by both both of my previous speakers. In the statistical analysis, they have found the 4 risk factors, that is like baseline Z-score more than being 2, age of fever onset less than 6 months, Asian race and CRP, in which the baseline Z-score more than 2, they have given a scoring point of 2, and the rest of the 3 criteria they give a score of 1. So in this, the low risk factor is 0 to 1, moderate risk factor is 2, and high risk is 3 to 5. So this scoring system they have developed using a development data set, and then they have validated. In the developmental data set, they have found that the odds ratio of CAA is 16-fold higher if they have a high risk factors. That is like when the scoring system is more than 3 to 5. But in the validation cohort, when they found like in the high risk scores group, it is more than 40-fold increase risk of CAA. So this is the article that Sir was talking about when he just before introduced us, the subgroup analysis by the Jane C. Burns group. So they have done a cluster analysis involving a 14 variable, and they tried to analyze the proteomics and the geographical and epidemiological data behind it, and then they have clustered it into 4 groups. The 4 groups are the one with the liver, one with the band shape, one with the node, and one with the young group. So the young age at onset patient, if you see, they have the increased risk of CAA. Even though the IVIG resistance rate they have mentioned like it is low, but they found like that those patients have like high platelet count, high lymphocyte count, and then they have high risk of CAA. The other group that I want to highlight is the one with the liver group. So the one that has like high transaminases, high bilirubin levels. Even though they are older age at onset, they have like high risk of IVIG resistance. So these are the 2 groups that I want to highlight, because like these 2 groups needs to be intensified with treatment at the onset. The other 2 groups that they have mentioned is like high band neutrophil counts. So, and the other one is the cervical lymph node group. The lymph node group has like intermediate risk for like CAA, IVIG risk and KD shock. But the band shape group, those who's having increased band neutrophils have like high risk of KD shock syndrome. So these patients also will require an extra treatment at onset only. So this study I want to highlight. So this is like we have talked about Kobayashi scores, Sano scores, Igami scores and everything. All those scoring system for IVIG resistance. So this is one of the scoring system that has been published recently in 2024 from China. So they have also had like a development data center and a validation data center and tried to make a scoring system. And this is a very complicated study, and they have derived such a complicated scoring system. So they have developed the scoring system for 2 groups. One is like medium or giant CAA group, and then for a CAA group. But I just want to highlight the factors that they have talked about. One is like male sex, age, total duration of fever, IVIG resistant platelets, and hypoalbuminemia. So in this, based on the scoring system, in the developmental set, they have found a sensitivity and specificity of around 86.9 and specificity of 81. And in the validation group, it is also like almost more or less similar, that is little more than 80. And in the giant CAA group, they have again did such a complicated scoring system. But the factors they have, there are like few factors that is extra compared to the medium group. In that is like the one is the hemoglobin they have added, that is low anemia is a risk factor, and ESR being higher is also a risk factor. So based on the scoring system, they have told like we can predict the giant CAA with a sensitivity of almost around 90 to 80, more than 85%. So coming to the other risk factors apart from the IVIG resistance and CAA, so there is macrophage activation syndrome is also a risk factor for development of CAA and having a severe disease. So a study from our unit only by Dr. Rakesh, they have mentioned like the CAA in the group with macrophage activation syndrome is almost around 41%. So the next group is like atypical KD. So atypical KD, why it is important? Because it is always difficult to diagnose KD at the onset, and there will be delay in the diagnosis, and these patients have high risk to develop into coronary artery abnormality or IVIG resistance. So in this study, they have mentioned like in atypical KD, the CAA development is almost around 64%. So this is also one of the group which needs intensified treatment. So this is updated guidelines of 2024. So they have mentioned like 3 things. One is like sun risk score, and apart from the baseline CA is more than 2.5 and infants less than 6 months. So these are the things they have mentioned. These are the patients that they have mentioned as high risk group for intensified therapy. So I have almost covered when do we need to have a primary intensification, that is like age, both the extremes, atypical presentation, severe forms, those with macrophage activation or shock syndrome or IVIG resistance, or the scoring system for both CAAs and IVIG resistance. If we put, then we have to hit hard at presentation itself. So why do we need to intensify in the beginning? So the goal of the treatment is like not just, one is like main is to prevent CAA, and then to have like long-term subclinical endothelial dysfunction we have to prevent. So we need to intensify for those patients with the high risk that I have mentioned in the previous slides. Coming to the treatment part, I think the treatment part more or less the drugs and the studies have been covered. So this slide has already been shown by Dr. Abe. So from the time that we thought initially prednisolone was not useful, then RACE trial, landmark trial like RACE trial has shown like prednisolone has been useful, and later there are trials for infliximab and cyclosporine and anakinra has come up. But the thing is like all these studies, even the RACE or KAIKA, all these studies, they classify patients based on IVIG resistance scoring system and then they intensify. There is no study which classify based on the high risk for coronary artery development and then they treat it. So I just quickly brush through the studies for steroids. So this is by Diana et al., in which they have found that with the steroids or infliximab, the CAA risk has been reduced to 23%, when if we use IVIG only in the high risk group, it was around almost 50 to 60%. And yes, for steroids, there is Cochrane review in which they have mentioned like steroids are better in reducing coronary artery abnormalities and reducing inflammatory markers, and there is shorter duration of hospital stay. And this is a RACE trial, like it's been talked so much in the previous talks, in which the CAA risk has been reduced from 23% to 3% if we have used prednisolone along with it. In this, they have mentioned like you used 2 mg per kg of prednisolone for 5 days and then taper it over the next 15 days. And infliximab, this has been widely used in USA, and then the studies are from Tremolay et al. And KitCare, and they have also found that infliximab reduces LAD, Z scores, and then the reaction rates of IVIG has been reduced, and the need for additional therapies has been reduced. And coming to the role of cyclosporine, and cyclosporine has been widely used because we know that 2 commonly involved genes like ITPKC and CASP3, which involves the NFAT and calmodulin calcineurin complex. So cyclosporine inhibits it. So they started trying cyclosporine. The important trial is the KAIKA trial, which has been mentioned previously. So I'm going to skip through. So this is the one important trial that they talked about is like these in the KD CAA prevention trial that's still going on from UK. So the inclusion criteria that they have mentioned is like any patients who's been classified as KD as per AHA, both complete and incomplete KD. So the exclusion are the one they have diagnosis it's very doubtful, or like CA at presentation, or like any other cardiac manifestation at presentation, or suspected macrophage activation syndrome. So this patient, like just with KD that we are diagnosing without, like they have not talked about the risk factors like rest of the trials like RAISE or KAIKA or anything. So this is like just KD patients, they are giving IVIG plus steroids in one group and IVIG in the other group, and they want to see the, as a primary endpoint how many of them has like CAA. So this might help that whether steroids is really helpful in patients with preventing coronary artery abnormalities. The study results are still pending. So the thing is like we talked so much about so many different drugs. So we know it will reduces the incidence of CAA, but in high risk infants, how much it is going to reduce? That is a real question, which we still don't know. In patients who are like high risk infants, like when CAA incidence is almost 50%, we don't know how much it's going to come down. So this is AHA 2024 guidelines, which shows the drugs that I think Pete has been previously covered. Prednisolone, methylprednisolone, infliximab, etanercept are the drugs that they have mentioned for intensification. Anakinra they have mentioned for additional therapies who are refractory to therapies. And this is a study from our institute. This compiled the risk factors for intensification, and the drugs that has been used is like either IVIG, infliximab, steroids, or cyclosporine. In cases that are needed, we can use all of them. So this is the treatment that we have used for the case that I have initially mentioned. So we manage the case using, we gave an IVIG, we gave infliximab, we have steroids, and we gave cyclosporine also, but still the child had persistent myocarditis, so we ended up giving a second dose of IVIG with 1 gram per kg. Finally, the child got discharged. So I conclude by saying we have to identify the risk factors, and there are a lot of risk factors. And treatment, it depends upon the countries and our expertise, and there are a lot of drugs that we choose, and sometimes we ended up giving multiple drugs. Thank you so much.
Thank you. So we have questions at the end of the 3 talks. The next speaker is Dr. Munish Arora, and he will be talking on Kawasaki disease shock syndrome, a condition that is often missed or diagnosed very late, and a condition where again the chances of complications are very, very high.
Thank you, sir. I would like to thank the organizers for giving me this opportunity. My talk will be on Kawasaki disease shock syndrome. So by definition, Kawasaki disease shock syndrome is a rare but severe form of Kawasaki disease in which patients present with vasodilatory shock, hypotension, and poor perfusion, with or without myocardial dysfunction. So going to history, it was first recognized in year 2008 by Dominguez et al., who reported 14 patients with KD who had hypotension and required management in ICUs. Then in year 2009, Kanegai et al. Introduced the term Kawasaki disease shock syndrome first time to distinguish this entity from the hemodynamically normal Kawasaki disease. What they found? They found that patients who had this syndrome had more severe laboratory markers of inflammation, and they were having greater risk of coronary artery abnormalities, including mitral regurgitation and prolonged myocardial dysfunction. Incidence of Kawasaki disease shock syndrome is different according to different literatures. In Mexico, it's 5%. Chinese report it to be around 1.2%. In our publication from PGI, we report the incidence to be around 3.4%. So definition was given by Kanegai et al. He defined Kawasaki disease syndrome, shock syndrome, as sustained presence of any one of the following conditions: either systolic hypotension for age, decrease in systolic blood pressure from baseline of more than 20%, or clinical signs of poor perfusion not accounted for by other conditions. All these would require the treating clinician to initiate volume expansion or infuse vasoactive drugs or transfer the patient to intensive care subunit. The etiopathogenesis is multifactorial. There will be some factor of vasculitis which will lead to cytokine dysregulation leading to capillary leakage and myocardial dysfunction. Coming on to clinical and laboratory features of Kawasaki disease syndrome, shock syndrome. This was a study done in China, published in 2019. They recognized patients of Kawasaki disease syndrome from January 2014 to October 2017. 2023 patients of Kawasaki disease were enrolled, out of which they recognized 27 patients of Kawasaki disease shock syndrome. 43 patients of Kawasaki disease who didn't have KDSS were chosen as control. What they found that patients who had Kawasaki disease syndrome, the mean age of diagnosis of Kawasaki disease or onset of Kawasaki disease was more than in patients of Kawasaki disease without shock syndrome. Also, they recognized that these patients had more days of fever, or the diagnosis of Kawasaki disease was made late. Approximate mean age was 10 days, on 10th day of Kawasaki disease. The other signs of Kawasaki disease like conjunctival injection, oromucosal changes, or lymphadenopathy, it was not significant. Mainly mean age was older and mean duration of fever was more. Laboratory features, the patients of Kawasaki disease syndrome had more WBC count, they had higher polymorphonuclear cells, hemoglobin was low as compared to patients, hemodynamically normal Kawasaki disease patients. Other significant changes or significant p-value was that they had higher CRP value, low albumin count, low serum sodium concentration. The Kawasaki disease shock syndrome is multi-organ. So the patient also had higher creatinine, higher blood urine nitrogen, involvement of myocardial dysfunction was recognized by higher CKMB value. D-dimer was raised in these patients and procalcitonin was also raised. They did serum cytokine levels in normal patients. It means that Kawasaki disease patients without shock and Kawasaki disease shock syndrome, the IL-6, IL-10 and interferon gamma, they all were highly raised or significantly raised as compared to patients with hemodynamically normal Kawasaki disease. Coming on to treatment and outcome measures in KDSS patients, these patients had significantly higher rate of coronary artery abnormalities. These patients also had more chances of aseptic meningitis as compared to hemodynamically normal Kawasaki disease patients. As expected, ECG abnormalities were more in these patients. These patients also had significantly raised IVIG resistance. They needed second dose of IVIG because of resistance, and also organ damage, other organ damage which include CNS and renal were also more in patients with Kawasaki disease shock syndrome. This was another study published from USA by Kanigawa et al. They recognized that majority of the patients who had Kawasaki disease shock syndrome as compared to without shock were Hispanic in ethnicity. Also, as mentioned by Dr. Aparna, band forms were more, neutrophilic band forms were more in patients with Kawasaki disease syndrome, shock syndrome. They had a significantly low value of platelet counts as compared to patients with hemodynamically normal Kawasaki disease. CRP was higher, and the patients also had IVIG resistance as compared to patients without shock. Coming on to cardiac manifestations, the patients with Kawasaki disease shock syndrome had more chances of coronary artery abnormalities, which included dilatations and aneurysms. They also had decreased ejection fraction as compared to Kawasaki disease without shock. Chances of mitral regurgitation were more in patients of shock. So they concluded that compared with hemodynamically normal Kawasaki disease, KD shock syndrome is associated with increased inflammation, more platelet consumption leading to thrombocytopenia, IVIG resistance, coronary artery abnormalities, mitral regurgitation, and myocardial dysfunction. Coming on to our experience, this was published as an abstract in ACR meeting 2019. Cases of Kawasaki disease from January 1994 to December 2018 were enrolled in this study. we recognized 810 cases of Kawasaki disease. 28% or 3.4% of patients had Kawasaki disease syndrome. Majority of patients were boys. Median age of diagnosis was 7 years. And all the patients of shock required inotropic support. IVIG was given to all of these patients as it is a standard of care. 3 patients required additional management with infliximab. 2 required second dose of IVIG, and 4 patients were started on steroids. 5 patients had coronary artery abnormalities. Out of all these patients, 1 patient succumbed to the illness. There is an overlap of Kawasaki disease shock syndrome with toxic shock syndrome. There is a role of superantigens in Kawasaki disease shock syndrome also. An 7-month infant who was autopsied when he expired due to Kawasaki disease shock syndrome, it was found that there is selective expansion and infiltration of variable beta-2, CD4 and CD8 T cells in the myocardium and coronary arteries of that infant. This variable beta-2 region is independent of T cell receptor, and it is activated only by superantigens. So superantigens play a role in pathogenesis of Kawasaki disease shock syndrome, but not in hemodynamically normal Kawasaki disease. So we have to differentiate patients of Kawasaki disease shock syndrome from toxic shock syndrome, because there is an overlap in clinical scenario in both of these syndromes. The patients with Kawasaki disease shock syndrome will be younger as compared to patients of toxic shock syndrome, but it doesn't mean that Kawasaki disease shock syndrome cannot occur in elder patients of Kawasaki disease. Kawasaki disease shock syndrome patients will have a lower hemoglobin as compared to TSS patients. They will have more coronary artery abnormalities, more chances of regurgitation lesions which will be caused by valvulitis, and they will have elevated thrombocyte count as compared to patients with toxic shock syndrome. Otherwise, fever, rash, oromucosal changes, eye changes can be similar in both. It is a differential diagnosis of KDSS and toxic shock syndrome. For management, as highlighted by earlier speakers, Kawasaki disease shock syndrome, we will need to intensify the treatment, either primary intensification whenever we recognize the patient to be having Kawasaki disease shock syndrome, or secondary intensification when the patient of Kawasaki disease, otherwise not being intensified with treatment, develops shock syndrome. Standard Kawasaki disease treatment is followed, IVIG with aspirin. Shock will be addressed with the fluid resuscitation and vasopressors. Repeat dose of IVIG or steroids or other immunomodulator drugs, anakinra, infliximab or cyclosporin will be needed as center preference, as per center preference will be needed. Plasmapheresis has a role in Kawasaki disease shock syndrome. So my take-home messages will be, whenever we get a call from ICU or PICU or any other intensive care unit for a patient of shock, we should also keep a possibility of Kawasaki disease shock syndrome. We should also keep a possibility of KDSS in a patient of toxic shock syndrome as a differential. As compared to hemodynamically normal Kawasaki disease, KDSS patients are older in age. They have a prolonged duration of fever, more WBC count, more neutrophils, higher inflammatory parameters, so CRP, ESR, procalcitonin, higher D-dimer values. They will have lower hemoglobin and albumin. They will present as a severe case of Kawasaki disease with hyponatremia, hypokalemia. They will be refractory to IVIG, presenting with more coronary artery abnormalities, and aseptic meningitis is more likely to be seen in these patients. They will need aggressive treatment including repeat IVIG or steroids or immunomodulators as per center preference. Thank you.
Thank you, Rohit. Now we have Dr. Pallavi Nadi, and she will be talking on another subgroup which requires intensification, that is KD in infants.
Thank you, sir, and thank you organizers for giving me this opportunity to come back as a faculty, which is exciting thing for me. So thank you, sir. Today I'll be talking about Kawasaki disease in infants. Initially, if you glance at the topic, it seems like a very small topic. However, one can understand why it has been given 10 minutes for discussion in this forum. So, Kawasaki disease below 1 year of age can be very challenging because they have very atypical type of presentation, and most of the times it's very difficult to clinch the diagnosis. Usually there is a delay in diagnosis as well as treatment. So let's start with the few cases that I saw during my residency. So this was a 2-month-old girl child, symptomatic since 1.5 months of age. She initially developed high-grade fever, some rash over the body which resolved, and then it developed into some verrucous type of lesions. And over the time, she became very irritable. She was very tachypneic. So a possibility of a sepsis was considered from the referring hospital. They gave multiple antibiotics. So she came to emergency. Our initial possibility, because she was a 1.5 month to 2 months old baby with something which looked like pneumonia. So initially our diagnosis also swept us away from Kawasaki disease. We were thinking more of Omen syndrome or a LCH, something like that. Until we saw this. We saw that the child was keeping the hands closed, but when we opened it, we saw that there was some desquamations. This was on day 2, day 3 during the admission. However, on day 1, it was very subtle. So this led us to think about Kawasaki disease, and then we did an echo which showed a large aneurysm in LAD as well as in RCA. So we treated this child with IVIG and steroids, infliximab, cyclosporin, and we also gave her enoxaparin. And finally, when she recovered, there was no rash. The nails had started showing Bose lines. So this second case is probably, it has got repeated multiple times in the last 3-4 days. But this also was an infant who presented at 5 months of age, probably 4.5-5 months of age, with fever, maculopapular rash, some redness which developed during the course, swelling around the left side of neck, possibly a lymphadenitis. He was treated elsewhere with oral antipyretics and antimicrobials. He continued to have fever. He developed more symptoms of failure. So that was when something like viral myocarditis was thought of, and child received IVIG. This was during the 4th week of illness. And then when he went for a follow-up at 10th week, the echo showed there was some dilatations of the coronaries. That was when the referral came to PGI. So this was possibly a Kawasaki disease which was missed in the initial presentation. So we also did the echo. We saw that there was a large aneurysm in the LAD with a thrombus which sitting over there, and his inflammatory parameters were still elevated. So we acted upon and gave him other medications like repeat IVIG, infliximab, and also gave him cyclosporin. So these two cases highlight why it is important to know that Kawasaki disease in infants can be different, and it can be, presentation can be totally atypical and incomplete. It has been seen that the incomplete presentation is seen in about 19 to 80% of the children, and diagnosis is definitely challenging because of this unusual presentation. So let's understand about the epidemiology of the Kawasaki disease in infants. Recently, there was a paper published from Japan about the epidemiology of these kids. They collected all the cases from the inception till 2019, before the pandemic. They had about 3 lakh cases, out of which 28,000 were less than 6 months of age, which constituted 8.7%. So when they charted the number of cases over the years, they saw there was a surge, there was epidemics 3 times during early and mid 1980s. During that time, there was a surge of other age groups, that is 6 months to 5 years. However, the 2 age groups which had very slight increase in case only were less than 6 months, that is the infants, and and more than 5 years, the older kids. Over the next few years, from 1985 to around 2002, there was a steady increase in cases of in all the age groups, and following 2020, probably because of earlier detection and more detection, there was increase in cases of all the age groups. However, if we see the curve of the infantile Kawasaki disease, it is more or less has been stable, and even though there has been decreasing, like in age above 3 years of age, the increase has been more than 5 times. However, in infantile Kawasaki disease, there was increase in only 2 times, factor of 2. And there had been major decrease in incidences, mean incidences. One was in 2016 and 17, other was during the COVID-19. So the other age groups saw a decline in cases during those time. However, there was no such decline in incidence of infants presenting with Kawasaki disease. This also opens a Pandora box of questions like what could be the reason for such decline only in adults, but there was not much of decline in cases of infants with Kawasaki disease. So is it a different etiology? Is it a same etiology? If it was a same etiology, why there was no increase during the epidemics? Also, when they observed the seasonal variation of the infants with Kawasaki disease, they found more or less a stable incidence over the months, with a slight peak in the month of June and August. However, in the other age groups, that is more than 6 months, and in the age group of 2 and above the 3 years, there was a significant surge in winter peaks, that is during the January and December in Japan. However, there was no such peak seen in infants. So again, possibly the epidemiology of is different, and possibly pathoetiology may or may not be different between the infant and older children. So is it because of the social factor that the infants less than 6 months are mostly kept at home, and more than 6 months they go to daycare or they go to school, and that's why they are exposed to various environmental factors that could be etiology or trigger for Kawasaki disease? Or are those infants who are at home actually developing Kawasaki disease because of the other older sibling who have other environmental exposures, or the trigger is different for both or is there a genetic susceptibility? Again, we don't have answers even after so many decades of the description of the initial disease. So if we come to South Korea, again, in South Korea also, there is a higher proportion, about 7.6% of children are less than 6 months of age. They also checked the difference in presentation between the two. They saw that coronary artery abnormalities of any kind and aneurysms were much higher in children less than 6 months of age when compared to the more than 6 months of age. They also compared whether there was any difference in male and female. Once the children are less than 6 months, they are just high risk. You do not have like male have got higher prediction for coronaries, or females have got higher. There is no difference such as. Once they are in high risk group, they are in high risk group. This is what we can take from this article. So from India, we have to know our own data as well. This is from PGI Chandigarh. So we have about 3.6% of children who are below 6 months of age, and about 88% of them have been incomplete presentations, and 35% of them actually developed a coronary artery abnormalities in follow-up. And there was a significant delay in diagnosis of more than 10 days in 12 of our patients, which constitutes 70% of our patients. So this actually shows that possibly a lot of cases of Kawasaki disease are missed because of the incomplete presentation. They may not actually reach to the centers where they can find treatment for this, and also because of this delay, there is a higher risk of coronary artery abnormalities in these kids. So moving further towards the west, that is there is a article from Italy which show that they have about 1.7% cases who are less than 6 months, and 28% of their cases are less than 1 year. They also have a significant delay and increase in incomplete presentations in that. And this was a very old article from US, which was for children with less than 1 year. They also showed that there was higher risk of coronary abnormalities in these kids, especially less than 6 months of age. So what has changed over years is the case definition that AHA in 2004 actually defined infants with less than 6 months having 7 days or more, fever of 7 days or more without any other explanation to actually investigate for the possibility of Kawasaki disease. However, in 2017, so any prolonged fever with irritability or unexplained aseptic meningitis or unexplained culture negative shock, cervical lymphadenitis or phlegmon. However, again, we do not have a exact criteria even till now, because in 2024 also the update has not mentioned much about it. So also, is it actually sufficient? The AHA criteria, is it sufficient enough to diagnose this? Because we also have children who can present without fever. There have been multiple reports across the world in infants, especially who present without even fever or maybe a short duration of fever, like 3 days or less. So in these kids, they have been detected to have coronary aneurysms in follow-up like in the 2nd or 3rd week. So coming to the Japanese guidelines, actually they mention fever without much emphasis on the duration of the fever, and fever is one of the principal features of the in the criteria. So they suggest if there is 2 or less principal features, and if there is any enlargement of coronary arteries during the period that we see, we have to think about Kawasaki disease and possibly initiate treatment for that. Again, this has got a caveat, because in country like India, where there is lot of resistance to acceptance of diagnosis of Kawasaki disease, especially in the peripheral settings, and when the children come with fever for 3-4 days with some focus like some cough or something, how many of these patients would need consultation with the pediatric rheumatologist? Will they be actually referred to a pediatric rheumatologist? Will the patient be able to afford a pediatric echo during that time, or whether that will be a financial burden? This is all what we have to take a balance of. And these are the challenges that at least I faced during my residency. The child is extremely irritable and have got high heart rates, and this actually and also when there is tachypnea which is actually added to it, there is a lot of movement, and we won't be able to point out how much of the aneurysms actually. And one more thing which would affect is the narrow costal window that is actually very difficult. You will have to manipulate the child, and by the time you manipulate, the child will open his eyes and starts crying. Again, it actually makes us difficult for us to assess the coronaries. So also there is a difficulty in visualizing the distal segments, especially in infants, and also pediatric expertise are not available in the periphery. So these are all the challenges, and again we have to balance, and finally it is probably to the clinician to decide and to cater the investigation for each patient, and it should be a balance. So infant and coronary infants have got higher risk of coronary aneurysm, especially those less than 6 months have got about 70% chance of developing a coronary artery aneurysm. So again, they have higher incomplete presentations, higher giant aneurysms also. Same thing has been reflected by various studies as well. And this study which has clustered, possibly talked about in the last few days, have also shown that young age at presentation have got, especially the youngest of them, they have got highest risk of coronary aneurysm, and we can predict it with a high platelet count, probably high percentage of neutrophils, or increased or fall in hemoglobin, as in our first kid who had hemoglobin of 5.2 at presentation, which actually led us away initially. But these are the cases where we'll need to take decisions immediately and possibly start treatment. So coming to the treatment has been covered in the past by the past 4 speakers. However, I will be just brushing through it. So basically in the latest update, it has been added that high-risk children less than 6 months of age, or those with SAN score more than 3, need primary intensification of the therapy with infliximab corticosteroid. However, this slide has been adopted from one of the previous slides. So unfortunately, we don't currently have any head-to-head trials or RCTs to actually say whether it will decrease the chances of aneurysm in follow-up when compared to those who are more than 1 year of age, where we have definite evidence that possibly it will reduce to less than 1% with primary intensification. So this is something which we'll have to think about in future. So to summarize, KD in infant tends to be very severe. They have unusual presentations, so we need to have a high index of suspicion in each patient whenever they have a prolonged fever, especially along with irritability, and they have a high chance of developing coronary artery aneurysm, and they give a very short window to treat before they develop a huge ballooning aneurysms. So primary intensification of therapy is needed in these children because they come under high risk. Thank you.
Can I request Agartha and Manish also to join Karali, and we can have a few questions. So, KD shock syndrome will always be a difficult diagnosis because these children are being managed in another unit and they would have their own perspective. And you would notice that several patients with KD shock syndrome have aseptic meningitis. So if a child is in the ICU and he has features suggestive of aseptic meningitis, that is very likely to be diagnosed as bacterial meningitis. And if you go and tell them that this child has AD when the CSF is not clear, no intensivist is going to accept it that easily. The problem with infants is that not only do they have very severe disease, but the presentation is almost always incomplete. So when you have a young child who is febrile, who is sick, and who has some features of Kawasaki disease but not all, and he may be in some other unit, diagnosis is not very easy to make. And not only do you have to diagnose these children early, you have to be very, very aggressive with management. So these are two of the most difficult situations that you can ever come across. If there are any questions on yeah, Dr. Puneet first.
Excellent talks by all. Two questions. One is when you say intensification, what do you mean exactly by the sequence? I mean, it will be IVIG plus steroids, then you add infliximab or steroid or cyclosporine, or you add all these three together. So, any clarity on that? Or is it a unit-wise choice?
It's predominantly a unit-wise choice, but generally we prefer infliximab before IVIG because it reduces the reaction of IVIG also. So if we
same day, same city.
Yeah, generally we give infliximab, that will be over 4 hours, then we will start IVIG. There will be, like within a few hours gap only we will start IVIG. And steroids, if we are like this case, I think with the case that I have presented, like within 2 days of IVIG, I think we gave steroids because like there is a component of fluid overload, the child also had myocarditis. Rates of reactions and everything.
Second question is, when we say intensification, is it just the age criteria, suppose the child is 4 months and in shock, absolutely normal coronaries, or you have to have abnormal coronaries before you start intensifying?
No, with just age itself, we generally consider because they have high risk of coronary artery abnormality. If we wait for coronary artery abnormality, then we can't reverse it. So it's better to intensify before.
So
and definitely, if the child has a shock, yes, it needs to be intensified.
One with coronary abnormality, one with normal coronaries, both are less than 6 months, both need intensification.
Yes.
Will there be change in number of drugs which we will give because there are 4 or 5 drugs which can be given?
It is a unit policy and then mostly the doctor's preferences, but we generally give infliximab and IVIG if the child is without having any other risk, but if the child has like much more severe disease like having coronary artery abnormalities and a shock, we tend to give more drugs.
It's a very difficult situation, and at that time you would generally not give too much importance to the coronary artery abnormalities. One, it will be very difficult to interpret and it will change from day to day. So the decision is clinical, entirely clinical, and that makes it even more difficult because this child may not only have the clinical features of KD, in addition he may also have macrophage activation syndrome. So the platelets may be going down, and then again some other colleagues may think this is sepsis. So these are very, very difficult situations, but any delay in therapy at this time can result in severe consequences, and we have seen them. These will be the most difficult aneurysm that we'll ever encounter in these patients.
They would mention ferritin anywhere. Is there any role of ferritin in macrophage? Kawasaki, these will overlap or
in patient who we are suspecting macrophage activation syndrome, then yes, definitely yes, ferritin we do.
Dr. Murugan?
So, we do give steroids so that the reactions to IV also has to be rolled out. But if there is no aneurysm in an infant, we go for 2 agents. But at the same infant with no aneurysm and who came late, then we add infliximab also to that thing. But again, it is differs from place to place. Essential part is the money actually, and this is one thing that we do. The second thing is that infants they do have higher chances of aneurysms and the severity is high, and that is not always due to the delay in diagnosis. So, is there any biomarker study between infants and the other category of children which shows that the biomarkers in infants is different? So that is my comment. And again, in that KD shock syndrome, what is the duration of IVIG infusion which we will suggest? Like, is it as like that usual recommended thing because of the volume overload and with concomitant kidney dysfunctions? So, if you have any evidence that the IVIG infusion duration in KD shock syndrome, that is for you. And for Rakesh, I think in that argumentation you have added male sex also. So, what's the evidence, like empiric evidence behind adding the male sex, like a 3-year-old boy versus 3-year-old girl without aneurysm, with the presentation maybe 6 days. So, will you still argument that PHI? So, that's for you. And fourth one is that, like, why you have added KD shock syndrome and in that argumentation? I think the standard of care for KD shock syndrome is always 2 agents. The argumentation is a bit different, isn't it? These are my...
So, multiple questions. But for the infants with Kawasaki disease, that the one with O subgroup, they have assessed that there is a higher platelet count and higher neutrophil count. But we don't have a specific biomarker to differentiate.
I want to add that subgroup analysis, the cluster analysis, they have also done a proteomics study. So based on that only they have divided.
So they found that
proteomics. It's an epidemiological, geographical and proteomics along with the laboratory and clinical parameters. Only they classify the 4 subgroups. So they have a proteomics, but I don't know exactly what is it. But yes, there is.
Duration of IVIG in shock.
The duration of IVIG.
Recommendation without shock is to be infused in 12 hours. But there are no suggested guidelines for duration of shock, for IVIG duration in KD shock syndrome patients. But practically speaking, the duration should be more, or IVIG should be given slowly but there is no standard recommendations.
Morgan has asked a very difficult question. So regarding the male sex, because whatever literature suggests that male sex has a risk factor for coronary artery and development of severe disease and coronary artery. So that is a suggested algorithm, and one of these are the risk factor for development of coronary artery disease. And second thing you asked regarding KD-Shaw syndrome. So KD-Shaw syndrome is again because whatever literature suggests that the CAS development is very high in KD-Shaw syndrome children. So again, these are the risk factors we have identified, and based on that, the case-based age basis, because we have also written that on the case-based case, we can intensify the treatment. So the agent, how many agents you want to use, that has to be decided on that case only. But one cannot restrict just at the IVIG. That's what we want to say in those that proposed algorithms. So basically, because if there are several risk factors like male sex, KD-Shaw syndrome, plus, then possibly you will give multiple treatment. If there are one risk factor, then possibly you will see like something like infant without any coronary artery disease. So you will treat with 2 agents, or maybe you will just wait and 3 agents. But if there is coronary artery disease and sick child, infant, you will give something all, whichever is available. So basically, you have to decide on each and every case. Regarding the IVIG infusion, recent AHA 2024 has suggested that whenever you have a significant myocardial dysfunction or KD-Shaw syndrome, IVIG infusion should be prolonged.
So I will reiterate the fact that you said that the KD-Shaw syndrome doesn't mean that the myocardial dysfunction has to be there. Probably it is due to the cytokine damage. Also, we may have sometimes a shock without myocardial dysfunction. Had medication.
Distributive shock.
Yes. Thank you.
I just want to ask the role of glycogen is blocked refractory patients, and in any particular patients can we use that over the other areas?
In Kawasaki disease shock syndrome, role of plasmapheresis is there in literature. Maybe it acts by removal of superantigens, and superantigens are theoretically proposed to be positive for KD-Shaw syndrome.
Supposedly, we are seated in general OPD, and some child came with previously had fever more than 7 days, and at that time they unknowingly started on steroids, and some days the fever was subsided and every symptoms are subsided, but now in 3 weeks he came with deformation and some changes in BCC, and now what we will do, and ECG we will done, coordinates were normal, and then we have to give IVIG, or otherwise we have to go with aspirin only.
As per AHA guidelines, IVIG should be given within first 10 days of onset of fever, or if inflammatory parameters are raised even beyond 10 days, or there are echocardiographic coronary artery abnormalities after 10 days. But what we follow in our institute is, if the patient even comes after 10 days without fever with coronary artery abnormalities, we prefer to give the treatment with IVIG.
I had a question around infants or incomplete disease. How frequently do you use NT-proBNP as a marker? This is more around the diagnostic part, but is there any relevance and do you use it in your practice?
Yes, so we do use it because it's usually elevated in patients with Kawasaki disease, and about 660 is something like a cutoff. In most of our patients with in infants with Kawasaki disease, we have found that there is already aneurysm. So in most of our patients it has been elevated.
Sometimes in incomplete disease we are not very sure 100% if the echo is normal, whether we have to. Sometimes it's the markers are not pointing towards KD completely. So if that is high, is that the specific marker?
No, sir. Basically, again the decision is taken clinically whether the kid actually fits into, or either it's for the clinician to decide, or whether the child is actually.
We could do NT-proBNP in almost all patients, almost all, because it's easily available here.
And to answer your question, if the patient has a normal coronary, we still take a decision we'll do inflammatory parameters. If they are elevated, we suggest that treatment would be better. If they are normal, we again leave the decision to the patients, parents. Most of the times we actually suggest them to take the treatment because there is always a risk of coronary aneurysm up to 6 weeks after the initial. Maybe that if you don't treat at 6 weeks, when we do an echo, maybe the child comes back, maybe having a small dilatation or something. So it's always better to treat.
This is applicable for children presenting after 10 days. Before 10 days, we have to treat irrespective.
Like the child has become afebrile, but now it's peeling stage. That's what.
I have a simple question. So, like in infantile KD, we do know that many a times they are more prone to developing coronary artery aneurysms. That may be because of a misdiagnosis or delayed diagnosis, but often it's not the case. So, is it so that they develop coronary artery lesion earlier? Like we classically know coronary artery lesions occurring in the second week of the illness. But does it so happen that in infantile KD they occur earlier in the course of illness? And if so, is there some data to suggest by what day does it happen? Is there a specific pattern to its involvement?
So again, the data differs across the region. So in the east, obviously they diagnose earlier. In spite of that, they have a higher risk of aneurysms. Even in Italian cohort, the median delay was just 8 days. On day 8, they had received treatment. Still, they had a higher risk of aneurysm. We currently do not have what actually is causing them a severe disease. We do not know what is the trigger or why they are responding differently. But possibly it is a question that needs to be solved. But currently, what we know is they have higher risk of disease. Whether or not they are delayed. Most of the Western, like the Italian, US cohort, and the ones from the Korea and Japan, they have treated even before 10 days because they have the pickup rate is very high in the peripheral areas also over there. So again, we do not know the answer.
Infantile KD, two signs I am more interested. One is the BCG reactivation. Another one is the perianal excoriation. It was very, very classical in the infantile KD, but in the West nobody gives the BCG. In our country, every children receive the BCG. Especially, particularly when infantile KD comes, can we adopt the guidelines or the Japanese guidelines instead of the AHI guidelines? Because it is very, very, very specific. There is no differential diagnosis there for the BCG reactivation, unless otherwise, like, are you dealing with the primary immunodeficiency? If it's MSMP, there is a BCG reactivation we have seen. If the patient comes with the fever with all these and other signs, in Indian setup, like, because we are receiving the children receiving the BCG, the Japanese guidelines will be like very, very essential and useful to pick up these patients very early.
Yeah, I think you're right. If a child is febrile and he has a BCG site reactivation, there is virtually no differential diagnosis. And the same applies to perianal discharge. That is a very important point that Dr. Satish has made. Okay, I think with this we come to this thing close for this session, and we have one more talk before lunch.
Thank you all for the interesting discussion. Now for the last session before lunch, I would like to invite Professor Manfu Singhal and Professor Deepti ma'am to chair the session.
Good afternoon, and we have an exciting journey of cases for coronary artery bypass graft in obstructive coronary lesions by Professor Sudha.
Thank you. I would like to present our experience of coronary artery bypass grafting in Kawasaki disease. This slide shows a patient with a giant aneurysm. Severe localized noise of the LAD was detected 7 years after KD. In the LAD, it's an indication for coronary artery bypass grafting in the LAD. The diameter of the right coronary artery increased 7 years after the onset of KD. There are no indications for CND in the RCA because stenosis. However, in Dr. Kobayashi, bilateral CABG was performed, avoiding reintervention to the RCA in the future. Left an ITA graft after operation was good patency. The right ITA graft after operation was also good patency. Clipping of the right coronary artery was performed to avoid complete graft flow and native flow. Measurement of ITA flow during operation. The ITA flow is preserved after clipping of the native flow. Parameters before and after were shown. LVEDP increased 9 to 11. LVEF almost same. Abnormal Q wave was detected in electrocardiogram after operation. Although this operation can be not always recommended, his outcome was good. The patient had bilateral segmental stenosis. In his elementary school, indication for coronary artery bypass grafting was discussed. We decided to continue medical observation because we thought myocardial ischemia was not severe because collateral artery are developed. However, he had ventricular fibrillation after exercise in 19 years old. AED was used and coronary pulmonary resuscitation was successful. He survived and underwent CABG and implantable cardiodefibrillator. And we thought coronary artery bypass grafting should be performed when he was elementary school. But his electrocardiogram is within normal. But myocardial ischemia was mild. We decided to medication at that time. The next slide shows angiogram in a 44-year-old boy. He had cardiogenic shock 1 day before operation. warfarin was stopped before operation, and heparin was administered intravenously. Warfarin should be continued until operation. Bilateral CABG was performed, and he could survive. Changes of left ventricular diastolic dimension and left ventricular shortening fraction were shown. After operation, beta blocker and enalapril were prescribed. His LVEF was improved. His admission in his electrocardiogram, V1 to V3 deep Q wave were found, and cardiogenic shock, bradycardia, and after operation, V4, V6, STT change. Next show, a 38-year-old male. He had acute KD, 2 years old. At 8 years old, coronary angiogram was performed, and it within normal range. Master double electrocardiogram, STT change was not detected. His follow-up was discontinued at 20 years old in the previous hospital. His coronary angiogram are shown. In his electrocardiogram is shown within normal range. But CTA angiogram, he had calcified coronary aneurysm at the proximal, the right coronary artery, and distal RCA were found. And aneurysm at bifurcation of LCA was detected. CTA imaging was shown. His coronary angiogram was shown. Localized stenosis of the RCA was detected, and aneurysm at bifurcation of LCA was shown. After 2 years, localized stenosis progressed. In his 8-year coronary angiogram, RCA was almost normal, but I think giant aneurysm regressed. In the left coronary artery, one more small aneurysm was detected in the LAD. He underwent coronary artery bypass grafting, such as figure. CT imaging after cabbage was shown. The both grafts were patent. Next case, a 6-year-old boy. He had acute KD in the age of 9 months. He had giant aneurysm in RCA and LCA. 1 year after KD, coronary angiogram shows decrease of aneurysm. The size of aneurysm decreased. 2 years after KD, localized stenosis of RCA at posterior descending artery. Myocardial ischemia was detected inferior wall of left ventricle. In 6-year-old, RCA was occluded and localized stenosis in the LAD was detected. We decided to coronary artery bypass grafting. "11 days after operation, coronary angiogram was shown. Internal thoracic artery graft was stenosis in the anastomotics. 3 months after, and we decided to balloon angioplasty for graft stenosis. And 3 months after operation, LAD was occluded. But 11 months after operation, graft is patent. He had another graft, GA, to fourth posterior descending artery. 3 months after operation, collateral artery to LAD were developed. But 11 months after operation, collateral artery were disappeared. Balloon angioplasty for anastomotic stenosis is useful. In this case, balloon angioplasty was done. Before angioplasty, almost occluded, graft is almost occluded, but after that, graft flow is preserved. He had no event for after operation. In 6-year-old boy, he had also balloon angioplasty 3 months after operation. Graft is patent after 20 years after operation. Next case, a 13-year-old male. He ECG anomaly was pointed out in 38-year-old. He was suspected cardiomyopathy, but coronary angiogram was done. He was probable KD. He was diagnosed probable KD. He had high fever at infant. LVD was occluded, and RCA segmental stenosis was detected. Coronary artery bypass grafting, bilateral coronary artery grafting was performed. But in 45 years old, left main coronary artery, LCA occluded, and PCI for LCX, PCI stenting was performed. But after 2 years, he had syncope because the left ventricular ejection fraction was decreased and cardiac recyclonidase therapy were inserted. Serial chest X-ray was shown. In a 14-year-old male, he had acute KD at 4 years old. He had underwent coronary artery bypass grafting, SVG to LAD, SVG to PL. At 44 years, coronary angiogram showed SVG occlusion to PL, and SVG to LAD is patent. Medication was aspirin and beta blocker. In 45 years, he had collapsed during exercise. AED was used. He survived. His coronary angiogram as shown. Segmental stenosis of the RCA was detected. SVG was patent. His myocardial perfusion imaging shown. Inferior wall perfusion defect was detected, and his LVEF was 36%. He had ICD implantation. Next case, one patient after CABG had chest pain. His electrocardiogram, STT depression was detected. His angiogram was shown. Bilateral internal thoracic artery were patent, but saphenous vein graft to the LCX, proximal of LCX was occluded. He had acute myocardial infarction due to massive thrombus in saphenous vein graft. In this case, he had chest pain at 30 years. Coronary angiogram showed plaque of saphenous vein graft and stent implantation for SVG. Many years after operation, degenerative change in saphenous vein graft can occur. It causes of acute myocardial infarction. Thank you for attention.
Thank you. It was very enlightening actually to see serial follow-up of these patients, not only having one procedure, but over 8 years they've had multiple procedures for survival. That's the emphasis is on the need for continued care in these patients. Can I ask you a question about, do you think collaterals that develop in small children are enough to prevent a CABG in most of the patients?
Yeah.
Collateral development, the
Yeah.
anatomy changes.
Yeah.
Is it helpful? Because in one of the patients you said collateral developed for lag, but then it disappeared.
Yeah. In small patient, the coronary artery, diameter of coronary artery is small, and the competition, between competition, native flow and graft flow is likely to occur. And balloon angioplasty is useful, I think.
Are there any more questions? So would you want to take up these patients early for cardiac surgeries? If a baby has giant coronary artery aneurysm, would you wait or take him up for surgery much earlier? How has your practice changed over the last 50 years? Are you taking children earlier for surgeries now?
Yeah. I don't know about that, sorry.
Are there any more questions? Thank you, then. Thank you, everyone. And I think we can go in for lunch. Thank you, ma'am.
Now we'll have a short break for the lunch. Welcome back all of you after the lunch break. So now we will having the oral presentations by the delegates. So for the first presentation, I would like to invite Dr. Manjunath for his presentation.
So I am presenting the case of hydrocele Kawasaki disease, the importance in the early recognition of particular disease. Further we know, we discuss about the mostly cardiovascular management, but we only focus about any particular cases in Kawasaki disease. So coming to the introduction, the Kawasaki disease is a systemic vasculitis that occurs predominantly in infant and young children. The typical presentations of Kawasaki disease disruption in the form of like intestinal pseudo-obstruction, tonsillitis, or hemorrhagic serous effusion like pleural effusion, cardiac effusion, and thrombocytopenia. But the acute scrotum is a rare entity and rare complication of Kawasaki disease and not as well recognized as other manifestations of the disease. So unexpected presentations such as testicular hydrocele, timely diagnosis is essential to reduce the treatment delay. So coming to the demography of my patient, the patient name is Shivang Nayan. He is a 4-year-old male child. The weight is 12 kg and height is 112 centimeter. Address from the Patna, Bihar. The duration of the stay is 10 days. The informant is mother and father. So coming to the case characteristics. So on presentation, the child has fever for 12 days and swelling and pain in the left sided scrotum for 7 days. The fever is continuous, high grade, the documented is 103 and associated with chills and rigors. And on the hydrocele, the swelling in the left sided scrotum is sudden in onset and progressive in nature, associated with pain and redness, not radiating to other side, not associated with any aggravating or limiting factor, and no prior history of trauma. So, and no association with cough, cold, difficulty breathing, vomiting, pain abdomen, and loose stool, headache, convulsions, altered sensorium, and any burning maturation, and rash over the body, redness of the tongue, red or cracked lips, and redness of the eyes, swelling of hand and feet, and skin peeling around the fingernails, and joint or bony pains. Coming to the examination, and local examination, there is no lymphadenopathy and any ictus pallor or edema and clubbing. And coming to the local examination, on scrotal examination, there is tenderness is present and there is local rise of temperature also, but the transmitter test is positive and I got the get above swelling is present. On systemic examination, we couldn't find any significant, like in RSS, even GIT, the liver is only 2 centimeters palpable, but the liver span is normal. We done the investigations and workup. The hemoglobin is 9.3. The anemia for the is less for the age, and WC count is rise, that is 19,280. Platelet, there is thrombocytosis, that is the 6,09,000, and elevated ESR 54. C-reactive protein is just borderline, and albumin is 3.54. There is increased ALT, AST, and alkaline phosphatase, and the procalcitonin is negative, and serum sodium 133. So, how we reach the diagnosis of Kawasaki disease? Initially, the child is presented in the outside the hospital for 3 days. They have treated in the line of infections and the child received IV antibiotics. Even though the child received IV antibiotics for 3 days, the symptoms were not resolved. For that, the child referred to our center. The child presented to our center on day 4 of illness. So we kept the differential diagnosis as acute epididymitis, but there is no on fluorescence, there is no urine routines, no pyuria, and urine culture is sterile. Fever is not subsided even after 10 days of antibiotic. Outside 3+, in our center is 7 days. We thought of torsion of testes, but UVC Doppler is normal blood flow and chromatic reflex is present. Coming to in MIC, we thought of MIC also, but the serum ferritin within normal limit, and there is no major renal or GI involvement, no myocardial dysfunction. And we screened for other atypical infections also, like scrub typhus, malaria, leptospira, dengue, and viral fever, and TB workup also negative, and no hematologic involvement, like no history of bleeding manifestation, and PBS is normal picture, and reticulocyte count is within normal limit. So even though the child do not have the typical features of Kawasaki disease, there is a history of prolonged high-grade fever with increased ESR, with presence of 4 laboratory criteria, like anemia for age, platelet count is 6,09,000, WC count is increased, ALT is raised. This lead to the diagnosis of incomplete disease of Kawasaki, along with the atypical presentation of testicular swelling. So in that time, we did the 2D echo, is a normal study. So the child received IVG on 7th day of hospital admission at the dose of 2 gram per kg, we infused over 12 hours, along with aspirin. The temperature pattern we can see on presentation child at 99 Fahrenheit degrees Celsius. Throughout the stay, the child received the antibiotic like injection, meropenem and vancomycin also. For that also the child was not responded. The fever is like higher, only 101, 102 degrees Celsius Fahrenheit. On the 7th day of administration of IVIG, the fever pattern slowly decreases and touches the baseline. You can see the scrotal swelling also. Initial on presentation, there is redness and increase in scrotum. After the IVIG infusion, over 7 days, the swelling is decreased. So some of the articles which have presented in the international journals, the first case was reported with acute scrotum in 1980. The child was with the duration of acute onset of scrotum and 5 days of admission. The resolution take over the 9 days. There are several studies like Psycho et al., Katayama and Mukherjee. They Cabini presented 5 case studies and JBK 2013. This article is on the acute scrotum in Kawasaki disease and 2 case reports in literature have taken from. So discussion, the accurate early diagnosis can avoid their unnecessary surgical interventions, and acute hydrocele can also be clinical feature of Kawasaki disease. So diagnostic dilemma, if the clinician have any diagnostic dilemma regarding inflammatory process, should always consider Kawasaki disease as a potential differential diagnosis. Thank you.
Nice presentation.
Thank you, ma'am.
Very different type of case report. You have shown that after IVIG, almost took more than 48 hours for the fever to come out.
Yes, ma'am.
So did you repeat echo any time or did you?
No, actually the child came for 3 times in our body follow. 3 visits also the echo findings are normal, ma'am.
IVIG in the patient was febrile even after 48 hours?
Ma'am, actually after 48 hours there is only 1 spike of fever documented, ma'am. After that there is no fever spikes.
Okay, and inflammatory markers, pro-BNP, everything else was normal?
Pro-BNP, ma'am, in a setting we haven't done actually. The inflammatory marker, the ESR, CRP, we did, ma'am, actually. That was in decreasing tendency, ESR. Sir, currently the child is receiving the tablet aspirin, sir. 3 mg per kg per dose. Currently the child is on the 5th week of the disease. Only aspirin.
I would like to invite Dr. Shreya Mehta for the presentation.
Myself, Dr. Shreya, graduate student from AIMS Patna. I'm going to discuss a case of giant coronary aneurysm who was treated for rivaroxaban for long-term thromboprophylaxis. So, Kawasaki disease, as we know, is the most common cause of acquired heart disease in children, and large coronary artery aneurysms are at high risk for thromboembolic and stenosis and acute coronary syndromes. So, according to the AHA, it is recommended that such children should receive antiplatelet and anticoagulant therapy, and the standard treatments used for this are usually warfarin and enoxaparin. However, injection enoxaparin in small children possesses different challenges. Direct oral anticoagulants like rivaroxaban have been recently FDA approved for pediatric children and pediatric population, and its administration is quite easy as well as its monitoring is easy. So we had a case of 17-month-old male child who had presented to us with chief complaints of high-grade fever, redness of eyes, and desquamation of hands and cracking of lips for last 6 days, and associated with bilateral swelling in the hands and the feet. So initially in outside hospital. He had received 5 days of IV antibiotics. As there was persistent fever even on IV antibiotics, he was referred to the local district hospital where he was diagnosed as a case of Kawasaki disease, and the first dose of IVIG was given on day 8 of its illness. As the fever was still persistent, a second dose was given in the same hospital on day 11 of the illness. Even after the 2 doses of IVIG, the child was febrile and so was referred to our center. On presentation, the child had following symptoms on examination, like cracking and redness of lips with this rash, perianal desquamation and swelling in bilateral hands. A 2D echo findings had shown significant changes. There was a large coronary artery aneurysm in the left ascending descending artery, and with a Z score of 13.95, and the in laboratory parameters was showing increased platelet count with raised ESR and CRP, and hypoalbuminemia with hyponatremia. So with the intensification of treatment, the child was started on infliximab, and after 48 hours of a period of afebrile period, he was shifted to the antiplatelet dose of aspirin, and clopidogrel was added. And for the thromboprophylaxis was started on enoxaparin prophylaxis dose. But the issues with the enoxaparin was that there was discomfort of daily injections, subcutaneous injections, which had to be given by the parents. Secondly, it was difficult to adjust the dose because the child was just 9 kgs, his dose was around 0.05 mg, and the available enoxaparin is at 10 mg per 0.1 ml. And it was very difficult to keep the anti-10A activity assay within the limits. Also, there was risk of recurrent infections, and the child had presented to us with multiple episodes of bleeding. This was a bleed on trivial trauma, also one episode of severe bleeding from mouth. Now, rivaroxaban, American Heart Association also says that we can consider direct oral anticoagulants, and rivaroxaban is given orally. There is no need for frequent monitoring, immediate onset and offset of action, few drug and food interactions as in case of warfarin. It has stable pharmacokinetic and pharmacodynamic profile. Its use in other heart diseases has been shown in the Universe trial, and but there are no RCTs comparing the different anticoagulants. The only available case series are one in which they had used rivaroxaban in an infant of 6 months, and a second case series in which the rivaroxaban was used in a child of 8-year-old with giant coronary artery aneurysms. This is a trial which is to be started in China for comparing rivaroxaban with standard anticoagulants which we use, such as enoxaparin and warfarin. So, concluding that the refractory KD, it has its early recognition and timely escalation of therapy is crucial, and large coronary artery aneurysms in Kawasaki required sustained prolonged anticoagulation and follow-up. There are no RCTs to guide the anticoagulation therapy, and direct oral anticoagulants, as we had discussed few days before, are safe and effective for thromboprophylaxis, especially in small children. And it has undeniable advantage over the warfarins and low molecular weight heparins. And further studies needs to be established for its safety and efficacy, and it can play a major role in future. Thank you. Ma'am, this cost around 2,160 rupees for a month. It's 2.5 mg tablet is available. That this child being under scheme, Jan Arogya scheme, he was getting it freely in our hospital. And rivaroxaban was available at our center. And in Pgimer, what is the dose normally you give? It was given at 10 mg per kg. It's 5 to 10. But as the child already had developed giant aneurysms. 10 mg dose was given.
Essential to monitor for platelet count going forward.
Sir, I didn't get.
Is it essential to monitor platelet count?
No, sir. Like platelet count for sir. The child is on aspirin, so platelet count monitoring for that as a side effect is very important. For long term, sir, you are asking for long term.
Continuously monitor during follow-up.
Yes, sir, we are keeping the child is on rivaroxaban for last 8 months, sir. And after that, there has not been any major bleeding episodes.
So, after this, for next presentation, I would like to invite Dr. Alfred for his presentation.
Good afternoon, respected judges and distinguished faculty and my dear friends. Today I will be presenting a case report. So this is actually being presented on behalf of my postgraduate MD Pediatrics post-graduation center. I was in Madras Medical College. I had seen this child during my MD days. So I'm presenting on behalf of Madras Medical College. So we had seen a 12-year-old girl who had presented with fever, rash over the abdomen and legs and abdominal pain for 5 days duration. Examination revealed a febrile, icteric and lethargic child with cracked and erythematous lips. She had reddish palpable purpura over the legs and hyperpigmented rash over the abdomen. Skin peeling over fingers was noted at admission itself. She had a cervical lymphadenopathy, tender hepatomegaly, and rest of the examination and vital signs were unremarkable. So the first picture demonstrates the erythematous and cracked lips and the hyperpigmented rash in the abdomen and the reddish palpable purpura in the lower limbs and the skin peeling in the finger at admission itself. Investigation revealed neutrophilic leukocytosis and thrombocytosis, direct hyperbilirubinemia with transaminitis, elevated inflammatory parameters. Ultrasound done showed mild hepatomegaly with periportal thickening, also peripancreatic lymphadenopathy with gastric antral thickening. Echocardiogram showed normal coronaries. So with the diagnosis of atypical Kawasaki disease, because of the abnormal ultrasound, we further did a CT abdomen that showed necrotic pancreatic and periportal lymph nodes with duodenal and gastric wall thickening with mild ascites. So because of the wall thickening with the lymphadenopathy, we had also done an upper, and child had severe abdominal pain. So we had also done an upper GI endoscopy that showed acute severe duodenitis and gastritis, which was correlated on the histopathological examination of gastric and duodenal biopsy specimens. Skin biopsy was taken from the skin lesions in the lower limb that also showed lymphocytic infiltrate, but the mucosal and skin biopsy were negative for immunofluorescence. This is the endoscopy picture of the inflamed gastric and duodenum. So we have an adolescent girl with provisional diagnosis of incomplete Kawasaki disease. However, the odd points were the hepatic involvement and severe acute gastritis and duodenitis with necrotic peripancreatic and periportal lymph nodes. So we had to search for literature if we were missing something. So on literature search, we found several case reports which documented jaundice as an unusual presentation. In fact, it is the second most common cause of acute febrile jaundice after viral hepatitis. 20% cases of KD have hyperbilirubinemia. The most common or most important mechanism of jaundice is biliary ductal compression by the mesenteric lymph nodes, which our child had, along with vasculitis of the hepatobiliary vessels. Then this is a case report where a child had presented with duodenitis leading to duodenal perforation as a complication of Kawasaki disease. In fact, there is also a research article in which 100 patients with GI manifestation and KD were compared with no GI manifestation and KD, 200 patients. So they found that the GI manifested children were more likely to have IVIG resistance and to develop coronary aneurysms statistically. Then we had this presence of necrotic lymph nodes in the abdomen. So we found an article from Japan in which 33 patients underwent lymph node examination, of which 26 were autopsies. So they have found that the Kawasaki disease can lead to lymph node changes not only in the cervical region but also throughout the body. And necrotic lesions were also found in the lymph nodes, possibly due to inflammation and also due to the circulatory disturbance and vasculitis. So all the loose ends were tied up, and then we took it as manifestations of Kawasaki disease, and we administered the child intravenous immunoglobulin and aspirin, with which there was rapid effervescence, relief of abdominal pain, and resolution of jaundice and rash. As you can see, the rash has completely disappeared in the first follow-up in the first two pictures, and this is the third picture shows a child at 1 year follow-up. Echocardiography was normal at discharge at 6 weeks and at 1 year follow-up. The take-home messages is KD can occur in adolescents, and it is the second most common cause of acute febrile jaundice after viral hepatitis, and it can present as acute surgical abdomen as even as a perforated duodenal ulcer. And it can involve not just the cervical lymph nodes but also lymph nodes throughout the body, and they may have necrotic changes. Actually, I think I still have time. The reason this case is memorable to me is that this was one of the challenging cases that I witnessed during MD, and this was a stimulating factor for me to pursue a career in pediatric immunology and rheumatology. Thank you.
Nice management also. And did you do the pancreatic enzymes also in this patient? Pancreatic.
It's not mentioned here, but it was normal.
And any Nikolsky signs was positive? Nikolsky signs for STS, did you do? For STS, Stephen Johnson?
No, ma'am. No drug history, ma'am.
There was no history.
Thank you, sir.
So for the next presentation, I would like to invite Dr. Gayatri for her presentation.
Very good afternoon, one and all. I'll be presenting a child with a devastating sequelae of Kawasaki disease. She's a 17-year-old girl. She has been under the follow-up since 3 years of age. So at 3 years of age, when she presented to us, she had fever for 15 days, rash for 12 days, redness of eyes and lips and tongue for 10 days. On examination, she also had periannual desquamation. Her investigation showed neutrophilic leukocytosis, thrombocytosis, and high inflammatory parameters. So with these complaints, she presented to us on day 16 of illness. She was diagnosed as a complete Kawasaki disease, and she received IVIG on the same day of admission. Cardiography was done on day 18 of illness and showed giant aneurysms involving the right coronary artery, left wing coronary artery, and left anterior descending artery. In view of coronary aneurysms and also resurgence of fever after IVIG, she received infliximab on day 20 of illness. So these are our echocardiographic findings. We can find that she had giant aneurysms involving the left wing coronary, left anterior descending, and a moderate aneurysm involving the right coronary artery. Though the LMC started showing signs of regression, LAD, aneurysm kept on increasing in size, and within 3 years of diagnosis, she also developed hyperacute shadow which was identifiable in the echocardiography. So at this point of time, she underwent catheter angiography, and it was confirmed that it was a calcification. She further underwent a stress myocardial perfusion scintigraphy, which showed a perfusion defect involving less than 5% of left ventricular myocardium. And she underwent a CT coronary angiography. We can here see the RCA aneurysm, fusiform aneurysm, and the fusiform aneurysm involving the proximal ad and LMCA. And here we can see the calcification involving the left anterior descending artery and right coronary artery. This picture again shows this diffuse dense calcification of the left anterior descending artery and aneurysmal dilatation of RCA with calcification. So the calcium scoring of this child was 2500, which was very high. Anything more than 400 is considered very severe. And the coronary arterial age was calculated to be more than 70 years when corresponding to her chronological age of 13 years. So she further underwent a cardiac MRI. Here we can see the left main right coronary artery aneurysm. Here the left main coronary and left anterior descending aneurysm. This is the native T1 mapping, post-contrast T1 mapping and T2 mapping, which were normal. And this is the first pass perfusion, which did not show any ventricular perfusion defects, and there was no early or late gadolinium enhancement. So this child was treated with IV agent infliximab in the acute phase, and she was started on aspirin and warfarin. She received a short course of low molecular weight heparin when she was suspected to have a clot because of the hyperechoic lesion. However, when it was confirmed that it was a calcification, she was started on aspirin. So this is a recent treadmill ECG stress test which shows ST depression in the V3 to V5 leads at the peak exercise, and it recovered spontaneously to normal at the end, by the end of test. So we are planning to do a coronary flow reserve for the child post adenosine triphosphate administration and exercise stimulated MR or echocardiography, and to decide on further revascularization procedure. So she has been advised to avoid strenuous exercises and avoid marathon. This child has been discussed via email consultation with Professor Jane Burns, Najib Dada, and Professor Etsuko Suda, and she was discussed. The child was discussed yesterday in person also, and we have decided that we'll further go ahead with coronary flow reserve. If the CFR is less than 2, she may require coronary revascularization, and if there is evidence of severe stenosis, a coronary artery bypass graft may be considered. So I would like to emphasize that the coronary artery injury in Kawasaki disease can be more than the injury caused by atherosclerosis. This child had a delay in diagnosis and leading to early calcification also. This type of severe dense dystrophic calcification is the first to be reported in literature, and this can predispose to major adverse cardiovascular events. I would like to thank all the faculty members, residents and PhD students and staff, and Professor Manful Singhal, Professor of Radiology and Lead Cardiovascular Imaging. Thank you.
You mentioned 16 days delay in the diagnosis.
Yes, sir.
15 days.
Sir, she presented to us on day 16 of illness, sir. Sir, before she presented to us, she has gone to multiple hospitals. She was treated with multiple oral antimicrobials and IV antimicrobials, considering a possibility of enteric fever. Because of persistent fever, she was referred to PGI, and when she came to us, she was having all features of Kawasaki disease. Sorry?
Was she on steroids also?
No, ma'am. For this child, she was diagnosed in 2010. She has received only IV agent infliximab. So that time we were not sure whether steroid can be given or not. So we had given her infliximab, and the intensification was with infliximab.
The size of her increased on further achieving again. Was anything else at
No, ma'am, there was no active inflammation in the foreleg, and the increase in size was because of the calcification, which kept on increasing and per se. Thank you.
So for the last presentation today, I would like to invite Dr. Ahmed for his presentation.
Good afternoon, everyone. So, I'm Dr. Jamal. I'll be presenting an interesting case of early onset severe coronary calcification in a patient of KD with coronary artery aneurysms. My patient is Master S. He's a 10-year-old boy, resident of Nagpur, and has been under follow-up at our center since 2021. That is about 7 years of age. Initially in Jan 17, this patient presented with classical features of the disease
with a high-grade fever, redness of eyes, oral mucosal changes, and a bilateral cervical lymphadenopathy. There was no history of associated generalized rash or dorsal edema of the extremities. Based on this, at about day 10 of illness, a diagnosis of Kawasaki disease was made, and he was treated with IVIG in an outside center in Nagpur and subsequently started on aspirin. Investigation at the time of presentation were that he had anemia for age, there was a developing thrombocytosis, there was a neutrophilic leukocytic response, and the inflammatory parameters were significantly elevated with ESR and CRP being quite high. The 2D echo that was done at the baseline revealed a left main coronary artery saccular aneurysm about 6.5 millimeters with an aneurysm of the right coronary artery. At this point of time, when the findings were the same, after about 14 days, warfarin was added. Serial echocardiography over the next 3 years revealed a persistence of giant coronary artery aneurysm in LMCA, whereas LAD and RCA were largely mentioned as being normal. At this point of time is when the patient got referred to us. In our unit, the baseline echo revealed a medium-sized aneurysm in the left main coronary artery with a giant aneurysm of left anterior descending with a thrombus extending from the distal LMCA to the proximal LAD. CTCA was done after about 2 days, where in the right coronary artery there were about 2 fusiform aneurysms, where with the proximal aneurysm showing mural calcifications. The left anterior descending also showed a giant aneurysm with a calcified thrombosed aneurysm, as depicted in the picture. And the LCX was also showing an aneurysm. This was mostly an aneurysm that was extending from the distal LMCA into the proximal circumflex. The calcium score was calculated, which was about 485. So the main highlight of the case is it's a case of very early onset calcification in coronary artery aneurysm. It is within 3.5 years of disease onset. When upon review of literature, mostly we consider the development of calcification on an average after about 10 years of the acute illness. And if there has occurred a large or a giant coronary artery aneurysm in the acute phase, it increases the likelihood of development of subsequent calcification. The persistence of such lesions also further adds on to the risk of development of subsequent calcification. Another article published by Suji and et al. About the late wall thickening and calcification in patients after KD revealed that if there is an acute coronary dilatation exceeding 5 millimeters, it can lead to late abnormalities such as coronary artery calcification, and the prevalence of which increases with age, and it is commoner in males. Around 10% incidence of aneurysmal calcification occurs at 10 years after the disease onset, which increases to 38% at 20 years and 72% at 30 years. Based on this literature and on the latest scientific statement of AHA on the update and diagnosis of management of KD, amongst the risk factor category of 5.1, they now suggest that if a patient has a large or giant aneurysm, which means either current or persistent, we should consider a baseline CTCA within 2 to 6 months, and then we may even consider it doing every 1 to 5 years, and it needs to be individualized for the patient. So based on this, my take-home messages are that the timing of CTCA actually needs to be individualized for the patient. It is not one size fits all. Follow-up CTCA with calcium scoring needs to be done earlier in patients with persistent coronary artery lesions or giant coronary aneurysms during the acute phase, and further research needs to be taken into this, and calcium scoring is an indispensable part of the follow-up CTCA in KD patients. I acknowledge my faculty members, fellow colleagues, residents, PhD students, staff, and of course, Professor Manful Singhal sir. Thank you.
I would say, our practice also use the same. The patient is very sick, very severe disease, and the patient, as I say, very interesting. I would change the word to challenging case.
Right.
Interesting for us, but for the family it is not. Interesting is a word which is taken another sense. It's a very, very challenging case and good presentation.
Thank you.
Thank you, judges, for judging this session. Now moving over to the next session. So I would like to invite Dr. Vignesh Sir, Additional Professor in the Department of Pediatrics, to chair the next session. Sanya ma'am.
Good afternoon. So we move on to the next session. So may I invite Dr. Sanya Sharma. She is an associate professor in the Emergency Department of Pediatrics. She is going to talk about innate immunity in the large disease.
Next story is
Thank you, Dr. Vignesh. So, good afternoon, everyone. So, I'll be talking about the role of innate immunity in Kawasaki disease. So, by now, I think we all are now aware of what is Kawasaki disease and what are its complications. So, I just want to reiterate that Kawasaki disease is an acute childhood systemic immune vasculitis of unknown etiology. The disease is complicated by coronary artery lesions, and it is characterized by abnormal inflammation and an atypical immune response. Genetic factors, particularly variations in genes that are associated with immune system, contribute to the risk of developing this condition. So, what is the role of immune system? What is the role of innate immune system in Kawasaki disease? So, an overt immune reaction is considered to be the dominant feature of KD, and significant activation of immune responses, especially of the innate immune system, is believed to be significantly associated with the development of coronary artery lesions. IVIG and monoclonal antibodies against interleukins and TNF-alpha, they inhibit the overactivated immune response efficiently, again signifying the role of immune system in the pathophysiology of this disease. So this would help us in further evaluating assessment of the innate immune responses, would help in further understanding of the cellular signature of immune cells, and that is what is required. So innate immunity plays a very important role in KD pathogenesis. If we see this histopathological photomicrograph, and this is the section taken from one of the autopsy cases of a patient with Kawasaki disease, we can see over here that there is lot of inflammation going on in the vessel wall, and these inflammatory cells are infiltrating not only the intima but also the media and the adventitia. So there is a transmural inflammation, and what was found on immunohistochemical analysis was that the immune cells, they were primarily composed of histiocytes, and the histiocytes dominated the inflammatory infiltrate. They were CD68 positive, and the neutrophils were also there, which were mainly infiltrating the media of the coronary artery. So in most of the autopsy cases, the monocytes and macrophages are found to be the dominant cell population, followed by neutrophils and lymphocytes. So histologically, coronary arteritis, it usually begins at 6 to 8 days after the onset of KD, and the inflammation rapidly involves all layers of the artery. And when the immunohistochemical analysis of the tissue sections is performed, it usually reveals presence of monocytes, CD68 positive, CD80 negative, CD163 positive macrophages, and CD66 positive neutrophils, and also lymphocytes in the arterial wall. But the major cell population found in these lesions are the cells of the innate immune system, that is monocytes, macrophages, and the neutrophils. And these infiltrating immune cells, they release a lot of pro-inflammatory cytokines like IL-1 beta and TNF, which also contribute to development of endothelial lesions and coronary artery lesions. The activated macrophages and neutrophils, therefore, they are believed to play a very important role in the inflammatory process in KD, starting from initiation of the vascular wall damage, that is the arthritis, vasculitis, up to the stage of aneurysm formation. So, starting with the role of neutrophils and how they damage the coronary arteries, very little autopsy studies have been there, and this is one of the studies where they have shown that the neutrophils, they infiltrate media and they usually damage the arterial wall in the initial phase, in the early phase of the disease. And although again monocytes and macrophages are the dominant cell populations, and usually the neutrophils, they appear and they peak in the early stage of KD, usually by 10th day of the illness. And in this picture you can appreciate that the neutrophils are infiltrating media and they are positive for neutrophil specific elastase, and the macrophages are positive for this CD68 stain, and some T and B cells are also there. So in this study they have shown that the neutrophils are involved in the damage which is caused to the coronary arteries in the early stage of KD, and the vasodilation can occur as a result of injury to vessel walls caused by neutrophils as well as macrophages. So at the tissue level we have seen that the innate immune cells, they are causing the actual damage and disease pathology. So this is one of the studies by Chen et al. Where they have performed what is known as single cell RNA-seq analysis. And in this technology, this is a very recent and a very robust technology by which we can analyze any tissue, any biological sample, peripheral blood, tissue specimens, and also the any biological material which we think that it could be involved in a disease pathology. So in this study what they have done is that they have isolated the peripheral blood neutrophils and found that the patients with Kawasaki disease, they show an increased signature of neutrophil activation genes which are associated with neutrophil activation. For example, interleukin 1 beta, CXCL8, IL6, S100A8, FC gamma receptor 1B, CCL3, L1, S100A9, PAD14, CCL4. So all these genes which are associated with increased neutrophil activation and chemotaxis, so they were found to be elevated in patients with Kawasaki disease. So in this study, they have done a comparative analysis of neutrophil mediated immune dysregulation, and they compared KD with severe COVID-19, wherein they found that a predominant increase in IL-1 beta, CXCL8, S100A8, A100A9 is increased, and these cytokines are associated with neutrophil activation. And this was found in both KD as well as severe COVID-19 patients. And they also showed that there are around 219 genes that were shared between COVID-19 and KD. And they, based on the single cell analysis, they separated these genes into two clusters. So cluster 1 genes were primarily associated with the activation of neutrophil chemotaxis, chemokines, cytokine receptors, and signaling pathways. So they overall concluded that overactive neutrophils, they mediate the immune dysregulation in KD, and they sharing overlapping gene signatures and molecular mechanisms with severe COVID-19. So this is another study wherein the neutrophils, they were again investigated, and in this study the platelet neutrophil aggregates were analyzed. And the role of these platelet neutrophil aggregates in patients with Kawasaki disease was ascertained. And we can see that these aggregates, they are gated over here, so they are positive for markers for neutrophils, that is CD11B, and platelets, that is CD41. So the platelet neutrophil aggregates, they were found to be significantly elevated in patients with KD, compared to the bacterial infection and normal healthy controls. And the patients who received IVIG had higher rate of formation of these platelet neutrophil aggregates compared to patients who received IVIG, post-IVIG, and patients in convalescent stage. And moreover, it was found that the platelet neutrophil aggregates, they were more prevalent in patients who developed the coronary artery lesions compared to those who did not. So another important aspect of the role of neutrophils is the formation of netosis, nets, which is neutrophil extracellular traps, and even these molecules, these nets, they have been investigated in these patients, and in this study by GIAN et al., they have found that the formation of neutrophil extracellular traps was significantly higher in patients of KD when the samples of neutrophils were stimulated with PMA, the stimulating agent. It was the neutrophil traps, they were assessed based on the expression of the DNA dye, that is fluorescent dye, DAPI, neutrophil elastase, MPO, and finally the overall expression, the formation of netosis was much higher in patients of KD when it was stimulated, the neutrophils were stimulated with PMA compared to KD without PMA, and also compared to the healthy controls. And the netosis, it also positively correlated with high CRP levels, the inflammatory markers, CRP, and also ESR. And there was increased formation of netosis, and it also correlated with NLRP3 mRNA expression positively in patients who developed NETs, the patients of KD with NETs, compared to the patients who did not develop NETs or who were without PMA. So the expression of NLRP3 and IL-1 beta was increased. The mRNA levels as well as the cytokine, the serum levels were also increased. So this was one of the studies from our unit by Dr. Ayush Srivastav, his MD thesis, wherein again the patients of KD, they were investigated for the presence and formation of NETs, and it was found that the NETs were much higher in KD patients compared to the healthy controls. And these were the dyes that, which were used, again DAPI, MPO, and SYTOX, Cytox. So these dyes were used, and the formation of NETs was seen by immunofluorescence imaging. Now, what is the role of monocytes? So at the tissue level, again you can see and appreciate that the monocytes, they play a dominant role. Although we don't see monocytosis in peripheral blood, but at the tissue level, at the level of coronary artery lesions, the monocytes, they are the dominant cells which infiltrate the vessel wall and involve all layers of the coronary arteries. And so the monocytes have also been evaluated in multiple studies, and a recent study by Zheng et al., which is again a single-cell RNA-seq based study, evaluated 2 KD infants and 2 healthy infants. And in this study, again, a very unique finding of this study was that the KD infants, they had increased levels, they showed enriched population of KD classical monocytes. So this was a subset of monocytes that was found in patients, in infants with KD, which were CD14 positive, CD16 negative. And these, the KD-CMs, KD classical monocytes, they expressed higher levels of certain genes, for example, cell and MELAT1 gene. So these monocytes, they were also evaluated by flow cytometry, and again, they were found to be higher in patients with KD compared to the healthy infants. And subsequently on gene ontology analysis, it was found that these monocytes, they are associated with, or they are contributing to the myeloid leukocyte activation, neutrophil activation and degranulation, and so primarily activating the neutrophils. And finally, they concluded that this KD-CM subset, KD classical monocyte subset, that is expressing this marker cell, was associated with neutrophil activation, and this could be responsible for causing vasculitis in patients with KD through activation of neutrophil inflammasome. Another interesting study by Wang et al., again utilizing this single-cell RNA-seq strategy, evaluated 7 KD patients and 3 healthy controls. And in this study, they found that the patients of KD, before receiving IVIG, they had higher percentage of CD16 positive monocytes compared to those who had received IVIG, and also compared to the healthy controls. And the heat map of this single-cell seq analysis shows that patients who had not received IVIG therapy and treatment naive, they expressed genes that are associated with or encoding for complement and complement receptors, cytokine receptors, immunoglobulin receptors, and S100 proteins, and there was down regulation of MHC class 2 genes. And these monocytes, they also expressed higher levels of pro-inflammatory cytokines like TNF, TGF beta, S100 proteins, interleukin 1 beta. So again indicating that these are pro-inflammatory monocytes and they are playing a dominant role in acute phase of KD. So in this study, so the monocytes were the predominant cell population found, and most of the differentially expressed genes were coming from these monocytes in the acute phase, and they were expressing these pro-inflammatory mediators at a higher level, along with immunoglobulin receptors, along with reduced expression of MHC class 2 genes. Another nice study by Liu et al. Showed that the patients with Kawasaki disease, they they have a subset of monocytes which express these markers, again a unique subset expressing cell CCR1 and XAF1. So this subset of monocytes is enriched in patients with KD, and they performed multiple tests like single cell seq, flow cytometry, and showed the immunofluorescence-based expression of these markers in these CD14 positive monocytes. So here you can see that the patients, the KD patients, they are expressing the monocytes of these patients are expressing these markers like DY-SF and XAF1. So this specific subset is enriched in KD, and it was also found to be enriched in patients with COVID-19. However, these cells, they were not found in patients with influenza and also in healthy controls. And when the silencing of the genes was performed, the genes expressing for these monocyte markers CCR1, XAF1 and cell. So on silencing the genes for these in these monocytes expressing these markers, so it was found that along with silencing of these genes, the expression of the cytokines, the pro-inflammatory cytokines, was also reduced in KD and COVID-19 patients compared to the healthy controls. So in this study, so this subset was found, that is cell positive, CCR1 positive and XAF positive subset, which was found to be involved in vascular adhesion and injury to endothelial cells. The biological function is that cell and CCR1 genes, they mediate the interaction between monocytes and endothelium, and ZAF1 regulates the cell-to-cell adhesion, mediated damage and apoptosis. So the silencing of these genes can lead to reduced monocyte and endothelial adhesion. So we have also published a review article from our unit, and in this review article we have also highlighted the role of this single-cell RNA-seq in assessing the innate and adaptive immune responses at single-cell level in KD patients. And again, by using this technology, this thing, we can identify unique subsets, unique rare cell populations in KD and in our patients, and we can also, see whether these populations can be used as diagnostic biomarkers by validating them with other techniques like flow, and whether these specific populations, whether they correlate with the clinical phenotype like the coronary artery lesions, IVIG resistance. So all this can be taken up on a research basis. And in our center, we have also done a study where the monocyte platelet aggregates were assessed in children with KD. And the study was DM thesis of Dr. Vignesh, and in this study, the monocyte, just like neutrophil platelet aggregates, monocyte platelet aggregates were assessed by flow cytometry, CD14 and CD41 dual positive cells. So these are the monocyte platelet aggregates, and again the rate of formation of these monocyte platelet aggregates was significantly higher in patients of Kawasaki disease, especially at the time of enrollment or admission compared to the febrile controls and healthy controls. And these monocyte platelet aggregates, they persisted for quite some time, and they were found to be present even at 3 months after receiving IVIG. So these can also be, these monocyte platelet aggregates, so they can be further investigated and in further studies, in larger studies, and they can also be used as potential diagnostic and prognostic biomarkers. Then in our unit, we have also done a DM thesis where we have investigated the role of PD1, PD-L1 axis. So in this study, we have analyzed the monocytes again by stimulating them with interferon gamma, culturing them overnight for around 12 hours, and assessing the expression of PDL1. So PDL1 is expressed on monocytes when they are stimulated in normal health, conditions, and the usual pathway is that this interacts with PD1, which is expressed on T cells, and it blocks the downstream TCR mediated signaling of T cells. So this was the DM thesis of Dr. Pallavi, and in this study we found that the patients of Kawasaki disease, they had lower PDL1 expression when the monocytes were analyzed compared to the healthy controls, and also compared to the other non-KD disease or febrile controls. So I just want to conclude by saying that Kawasaki disease is characterized by complex dysregulation of immune cells, and it can involve multiple immune cells, innate as well as adaptive. Identification of new genes and the rare cell types, which could be KD specific, may serve as potential disease biomarkers. And these new subsets, the new cell types, they may be associated with IVIG resistance or severe coronary artery lesions, or with atypical phenotype and may vary from patient to patient. So we can explore this technique, and we can do functional validation. In vitro, in vivo models can be, they can be performed to actually validate the biological relevance of the findings that we get from single cell seq, and this will help in, it will contribute to the pathophysiology of disease, and may give us newer insights into the disease pathophysiology, as well as will help in exploration of novel therapeutic strategies. So thank you.
So do we have any questions? Yes.
Yeah. So the topic was innate immunity. So yeah, there are studies where the role of adaptive immunity has been explored, and again the single cell RNA-seq was primarily used to evaluate the immune cell composition in patients with KD. And in such studies, they have shown that the B cells, the role of B cells primarily, abundance of B cells, and they are expressing certain marker genes in patients with KD. And in some studies, they have done pre and post IVIG analysis of these B cells or adaptive immune cells. And in one of the studies, they have shown that the post IVIG, the B cells, they reduce, and the plasma cells with a specific phenotype, so they are increased. So there are studies on that as well.
Dr. Sakia, are there any studies on type 1 interferon signature?
Type 1, sorry, I didn't come across any.
There are no...
In one of the studies, like the single cell RNA based study only, they have shown that these monocytes, a subset of monocytes, so they are enriched in genes which encode for interferon alpha receptor. But specifically type 1 interferon.
Overall, the disorders that respond very beautifully to anti-DNF agents, they are more common in things like Behçet's, HLA-mediated reactions, and even Kawasaki disease. Diseases where high interferon signatures, they are more common in like glucose and GIAN. So something to do with XL Y chromosomes.
Yeah, and most of the studies have shown the elevated TNF and IL-1 beta and the respective genes for that. So, I mean, these patients, we have a large cohort of KD in our center, and since we have also got this 10x genomics apparatus, so we can also try doing this an analysis, because you can get a whole spectrum of what is happening at all stages, in acute stage, in convalescent stage. So multiple and even new cell types can be identified. So they can be further analyzed by functional validation in cell models or by other techniques like flow. So, I mean, we can also try and take up this in our patients.
Thank you. Thank you, Dr. Sakia.
Thank you, ma'am, for the talk. So now for the final session of the day, I would like to invite Professor Sujit Singh, sir, and Dr. Sanjeev Naganur, additional professor, to chair the last session of today.
I think over the last 4.5 days, what Dr. Suda has highlighted is the long-term follow-up, the long-term management of children with Kawasaki disease. And her talks have served to highlight the fact that we still have to do a lot of catching up in this condition. So in India, now at many centers, diagnosis of the acute KD is being made, treatment is being given, but where I think we still have a long way to go is on the long-term follow-up, long-term management, and the transition from pediatrics to adult. So this talk will be on PPCRA, that is percutaneous transluminal coronary rotational atherectomy, which is often required in children who have calcified coronaries. So she will be talking on this. Dr. Suda, please.
Good afternoon. I greatly appreciate Professor Singh and Sinha and all person concerned in the conference. The talk is case-based approach percutaneous transluminal coronary rotational atherectomy for obstructive coronary artery lesions. This 3-year-old boy had 2 months after the onset of KD, vomiting. His electrocardiogram, ST depression at 1V3, V6, abnormal Q wave at 3 were detected. After 2 hours, intercoronary thrombolysis, rokinase, was successful. On the next day, coronary artery bypass grafting was performed. Coronary angiogram 8 years after coronary artery bypass grafting, the LAD was occluded, but graft is patent. This angiogram shows after ICT was successful. "15 years after CABG, left internal thoracic artery was patent. However, he had localized stenosis in the left circumflex. Serial coronary angiogram was shown. Localized stenosis with severe calcification was detected. Rotational angioplasty were planned to him. PTCRA was performed. The first time, the use of bar size is 1.5 millimeter. And second time, the use of bar up to 2.0 millimeter. Immediately after, the finding of intravascular ultrasound was shown. Severe calcification was detected. However, he had restenosis 1 year after PTCRA, and PTCRA was performed. The use of bar size 2.15 millimeter. If the larger bar is used, the minimum lumen diameter is large, and the vessel is maintained. However, he had obesity and hyperlipidemia at 30s. Left ventricular diastolic dimension was increased, and left ventricular ejection fraction was decreased. Pulmonary hypertension was suspected. Although examination was recommended, but he didn't follow the advice. He had collapsed. He collapsed while working. he had coronary pulmonary resuscitation. Cardiopulmonary resuscitation was successful. He had emergency coronary angiogram. Severe stenosis in the left circumflex was detected. In the other hospital, PTCRA was performed, but dissection was detected and stent is implanted. Coronary angiogram shows segmental stenosis of right coronary artery. Left internal thoracic artery was patent. His electrocardiogram is shown. ST abnormality was detected. He had ischemic cardiomyopathy. Left ventricular dimension was 78 millimeter. Chest X-ray CTR was 60%. He had left ventricular assist device for waiting heart transplantation. Parameters before and after heart made to implantation. Mean pulmonary artery, left ventricular diastolic dimension, and BNP were decreased after implantation. In the other patient, he had PTCRA at the age of 25 years. The birth size was 2.4 millimeter. PTCRA was successful. FFR was 0.69 to 0.84 increased. This patient had acute myocardial infarction 3 months after PTCRA. This patient had a two-vessel occlusion and had undergone PTCRA on the other vessel. In this patient, coronary artery bypass grafting should be desired, such a case. This patient underwent PTCRA at the age of 5 years, immediately after successful. But 1 year after coronary angiogram, his right coronary artery was occluded, and coronary angiogram at 16 years, segmental stenosis was detected. 32-year-old male was diagnosed as scarlet fever at the age of 3. He was obese and dyslipidemia. He had chest pain, and the emergency coronary angiogram showed occluded the left anterior descending artery. Stent is implanted. Massive thrombus was aspirated. This figure shows 11 years and 16 years. This patient had chest pain with dyspnea during jogging. he had cardiogenic shock, emergency coronary angiogram, LVD was occluded, and aspiration was balloon angioplasty was performed. However, stenosis is not improved, and stent implantation was performed. His electrocardiogram showed ST elevation V1 to V4. His coronary angiogram showed occluded the LAD, and aspiration and balloon angioplasty performed, and stent implanted. His left ventricular aneurysm of the apex of left ventricle. He had cerebral infarction 3 years after PCI. He had warfarin was prescribed. 6 months after CAG revealed 25% stenosis in the stent. CTA imaging was shown. Severe calcification was detected. First generation stenting, some side effect was reported. Malposition of stent was reported. This angiogram, previous patient, and right coronary angiogram regressed at the age of 21 years. This patient had localized stenosis of the LAD at the age of 2 years old. She had underwent balloon angioplasty. Follow-up coronary angiogram was shown. At the age of 21 years, coronary angiogram showed small new aneurysm. Result of balloon angioplasty in patient more than 5 years, the result was not always good. In conclusion, PCI treatment is improved remarkably in the future thanks to improved device. However, appropriate patient selection is critical. Long-term follow-up is mandatory in this population because most patients are young. Thank you for attention.
Long-term outcome after coronary stenting. In Kawasaki disease with coronary obstruction is not that great, not that good. But in the acute setting, when a child or an adolescent having acute myocardial infarction, I think this is the treatment of choice rather than waiting for bypass surgery even for a few days. So what is your take?
Emergency PCI recommended in medicine in adult but in small children it is difficult to undergo PCI and depending on age, PCI is selected, I think.
As ma'am is saying, so when the calcium load is high and it is very calcific, we need to use this rotablation, rotational atherectomy, which starts with the size 1.25 millimeter, then the burr, which rotates at 120 to 200,000 revolutions per minute. So that we give, that goes over the wire and keeps rotating. So that will help us to cut down this calcium, which is eventually goes down and engulfed by the macrophages, the calcium powder sort of things. So the smallest available is 1.25 millimeters. And the recommended size of burr is 50 to 60% of the vessel size. So 1.25 if we are using, the vessel diameter should be at least 2.25 to 2.5 millimeters. For somebody to have 2.5 millimeters, what should be the body surface area or weight of the child? So that is one of the technical challenges in addressing calcific coronary artery disease in smaller children. So that's what I think she's trying to say. In smaller children, it is really tricky. If the size is 2.5 millimeters or more, then it is relatively easy. Or if the calcium is less, then the things are much easier. Because if the calcium is 360 degrees, whole of the circumference of the vessel, I am talking about the media and the medium of the coronary artery. If that is involved, more than 270 degrees, if you go clot sort of thing, then the bed preparation or the plaque modification will be really difficult. The crossing of the balloon, crossing of the stent will be tricky. And the stent expansion and opposition to the wall of the artery will be very tricky. And these are the things which determine the long-term outcome of these stents. Whether it's going to have stent thrombosis. Inadequately expanded means there is chance of neointimal proliferation and reatherosclerosis, especially in subgroups, which are inherently at risk of rapid progression of atherosclerosis or the coronary artery lesions. So that is the technical thing. And because the population is very less, so the industry is hesitant to produce such smaller bursts because they have to have so many people who are getting benefit from it. So then that is one of the challenges. So the other options are, which are coming up in last 6 years, I think, in India. What I was talking in the morning, in IVL is intravascular lithotripsy. The smallest balloon is 2 millimeters, and that the ratio is, we can use it as 1:1 ratio. For 2 millimeter balloon vessel also we can use that. So, but the thing is, that is very costly. It costs around 4.5 to 5 lakhs. So if you use more, then the cost will come down. But that is an option, even in calcified lesions. And orbital atherectomy is another newer technique which is used to tackle this coronary calcium. But that also is only for the vessels which are more than 3 millimeters. So for smaller sized vessels, the options with us at present are the cutting balloons, the balloons with the sort of wire, nitinol wire on the sides of the balloon, which gives relatively, I can say, some 50% of that of this atherectomy, which can be utilized as a bailout procedure, not as the best result, but in sicker patients not fit for surgery, or surgery is delayed for whatever reasons, in acute settings. These are the things which can be done. It is possible, but not the best concerned, as far as long terms are concerned, and in the present stage. Should be okay next few years. Any questions from the floor?
World has more experience of long-term follow-up of these children than Dr. Suda. And the center at where she works, MCVC, that is virtually the Makkah of follow-up studies in Kawasaki disease. And she had the privilege of working very closely with Dr. Pgimer, who is the legendary Kawasaki surgeon. There are many publications in which Dr. Suda and Dr. Pgimer have worked. So, thank you very much. Thank you. I would now ask Dr. Rakesh to conclude the
गलती तो
Good evening all. We have reached to the almost last GIAN program, which was for 5 days. So before tea, I want to thank, because of which we are doing the GIAN. So I extend my deepest gratitude to the Ministry of Education, Government of India, for the global initiative of Academic Networks program. This visionary initiative has been instrumental in enhancing academic collaborations, bringing international expertise to the Indian institutions, and fostering a culture of advanced learning and research. GIAN has provided a unique platform for knowledge exchange, enabling scholars, researchers, and students to engage with global experts and gain insights into the cutting-edge developments in various fields. Now GIAN is coordinated by the IIT Hyderabad. I want to thank IIT Hyderabad, because of which we are able to conduct this GIAN program. A special acknowledgement to Punjab University, which is an institution for the GIAN program in the Chandigarh, for its invaluable support in organizing and hosting this program. Professor Gurjaspreet, who is a local coordinator for GIAN at Punjab University, is the man behind all the GIAN program in the Chandigarh. The university's commitment to academic excellence and research has greatly contributed to the success of this initiative. And this GIAN program stands as a testament to the power of academic cooperations,
reinforcing the Indian government's vision as a hub for intellectual growth and global engagement. So now we will conclude this session and will rejoin after the tea for an award ceremony.